3, 2, 1. Please start, sir. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on clinical updates in the management of breast cancer oncology up to date. With immense pleasure, I would like to invite Dr. Brigadier Rajeshwar Singh, who is Director Medical Oncology, Paras Hospital, Panchkula, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you very much, and good evening to all of you. And I welcome you all on today's this webinar. Basically, breast cancer, as we know, is the commonest cancer in our country, and especially in urban areas, it has become so common. I should say that it has become a public health problem now. Now, all over the world, the cure rates are roughly about 90% in Western countries, whereas in our country, it is still less, about 60% are there. But they are still higher than other cancers, This is one of the few cancers which can be detected early in our country. Though most of us have for other cancer, they come very late, and of course in breast also they also come very late. But still, many of our patients they come very early. So we, in a standard treatment protocol, generally we in any high risk breast cancer we give a standard treatment in adjuvant setting of AC followed by paclitaxel. Still, after that treatment, also many patients they keep coming to us back again and again with relapses, and once it relapses, it becomes a totally incurable disease. So basically, it is a very heterogeneous disease, and we need to do more than what we are doing at this present situation. So a lot of development has occurred, and especially in SABC21 this year, that a lot of new drugs have come in early stage. So it's very critical on our part that we do something more than what is happening to our standard treatment protocol in breast cancer. So now I have taken few of this. I try to bring out those things which are new and which are beneficial to our day-to-day practice also. And though the practices will be changing, but slight benefit to it. So basically, to start the ball rolling, first will be discussed on HER2 positive early breast cancer, and for that, I request Dr. Gautam Goyal, who is a consultant medical oncologist at Max Super Specialty Hospital, Mohali. He's our senior colleague, and he'll be chairman for this session. I'll request Dr. Gautam Goyal to conduct this session, please. Thank you.
Good evening, sir. So we will be starting the first topic in HER2 positive early breast cancer. So taxanes with anthracycline versus taxane without anthracycline. Meta-analysis of near about 16,500 patients by Dr. Javed Muzammil. Dr. Javed is a consultant medical oncologist in Super Specialty Hospital, Srinagar. Over to Dr. Javed.
Thank you, sir. I think my slides are well seen and it's in presentation mode.
Yes.
Thank you, sir, for giving me opportunity today to speak on this topic. So I'll be speaking on this breast cancer symposium update about the topic that has been discussed by Dr. Gautam, that taxanes with anthracycline versus taxane without anthracycline. What is the present day meta-analysis that was done in 2021 by Early Breast Cancer Trialist Collaborative Group. So the background is that we use anthracycline and taxanes chemotherapy for early breast cancer to reduce the risk of the breast cancer mortality by about 1/3 in patients of the breast cancer without chemotherapy. So 1/3 reduction in the mortality by using the chemotherapy. But we know that there are long-term toxicities and immediate toxicities associated with the chemotherapy, either cardiovascular or leukemia or neuropathy. So there is increasing use of now non-anthracycline based chemotherapy because of recent updates about that anthracycline is not needed. So what was published in what was presented in this symposium. So aim is to better characterize the benefit and risks of the anthracycline and taxane chemotherapy for early breast cancer. And a meta-analysis was done in those trials which were published before 2012. and in which all the patients had received 6 cycles of chemotherapy at least. So at least 16 trials were taken into consideration, and they comprise around 18,000 patients. And the treatment groups that were divided into A, B, C, D, in which they received either concurrent anthracycline or sequential anthracycline, which we give as AC followed by T or EC followed by T. So the grouping was like that, either concurrent or sequential. So anthracycline was there in one of the arms. So we can see the analysis of these 16 trials. First of all, as far as the recurrence score is concerned, we can see from this that those patients who received taxanes with anthracycline, whether concurrent or sequential, there was drop in 10-year recurrence by 2.5%. So those patients who received the concurrent, those who received the combined treatment with the anthracycline and taxanes, there was a drop of recurrence by 2.5%. And and second is that breast cancer mortality, this overall in these 16 trials, the mortality was, there was a gain of 1.6%, 10-year gain of mortality if we use anthracycline with the taxanes. So this is a forest plot that again shows that there is trend towards benefit in all the trials that were taken into consideration in patients who received taxanes plus anthracycline. Then further subgroup analysis was done in these 16 trials, where they were grouped in Group A and Group B. And Group A is that group which had received the anthracycline as concurrent, like we have TAC, the taxane, this plus anthracycline and cyclophosphamide. So in concurrent group. And Group B is that group which received the anthracycline, but in sequential way, AC followed by T. So these were the characteristics of those groups. ER positivity rate was 66% in Group A. It was higher in Group B. Node positivity was 61% in Group A. So overall, the Group A was slightly having higher risk features than Group B. So here, the concurrent part, they received TAC, TAC, and the cumulative dose of anthracycline was 300 milligram and taxane was 450. And in the sequential part, they received epidubicin and cumulative dose was 300, and with docetaxel around 300 to 450 milligrams. Now we see that in the concurrent part, that is Group A, you see there's a huge difference of adding taxane with the anthracycline. There is 10-year gain of 8.7% in terms of the recurrence. So their recurrence dropped 8.7% times more in a concurrent group than those who did not receive the anthracycline. So it was in the concurrent group. And the second is the sequential group. Those who received the sequentially taxane with anthracycline, there was almost no much difference in the recurrence. There was only gain of 0.6%. As far as the mortality is concerned, in the concurrent group who received the TAC in the concurrent way, there was a mortality benefit of 4.2% with the anthracycline group, versus if we see the sequential group, there was no difference in the mortality, or it was only 0.3%. That was not statistically significant. Now, again, we see those patients having the high-risk features like nodal status positivity, whether N1 disease or N2 disease. This Foster plot favors this group, that if you use the anthracycline, having the high nodal status, they will favor this both recurrence as well as the mortality benefit. So toxicity and quality of life, which we have come across these trials, that combined analysis, if we say there was no statistically significant difference in death without recurrence, but there's no difference in death from the cardiovascular disease or leukemia, but the follow-up was for the period of around 5 years. So individual patient level data on the quality of life and toxicity is not available. Now, I have found this another article that which has been published in January 2022, the impact of anthracycline in intermediate and high-risk HER2-negative early breast cancer, which was a pooled analysis of randomized clinical trials, which is called as Plan B and Success C. So highlight here that for the conclusion part, for most patients with HER2-negative early breast cancer, ACT is not associated with severe benefit compared to only TC6. However, Patients who have high-risk features, lobular carcinoma, with nodal status of N to N3, they seem to be benefited with the anthracycline-containing chemotherapy. That is in contrast with the previous studies. So the conclusion from this symposium of this anthracycline plus taxanes was that there is 15% proportional reduction and 2.5% absolute reduction at 10 years in the risk of the invasive recurrence for anthracycline taxane versus taxane chemotherapy, and 42% proportional reduction seen with concurrent schedules, taxane dose same in both the arms, and the only difference was the addition of anthracycline. There is little, if any, benefit in the trials of the sequential anthracyclines and taxane versus higher dose of taxane in the control groups. So proportional reduction in the recurrence did not differ by the ER status, as we have seen that group A or in the group B analysis of the ER status of the nodal status. So benefit was across both the groups, whether ER was positive or ER was negative, but more benefit was in the ER negative group. But once we add that anthracycline. Thank you very much.
Thanks a lot, Dr. Javed. Our next speaker is Dr. Anubha. She is the head of the Department of Medical Oncology and Hematology at Patel Hospital, Jalandhar. And Dr. Anubha will be giving the update on soft as well as the text trials. Good evening, Dr. Anubha.
Hi,
Over
good
to you.
evening. How are you?
All good, ma'am. All good.
So good evening, everyone. I think I'll start sharing my slides. Just give me 1 minute. Okay, hope it's visible now.
Yeah, it's visible.
Yeah. All right. Thank you, and good evening to all the organizers, and welcome to all my co-physicians. It's nice to be here, although I guess we're all looking forward to an offline meeting soon. Anyway, that was a very interesting presentation by Dr. Javed, and the thing that I had on that was, but we don't use concurrent anthracyclines and paclitaxel currently, so I don't know, the relevance so much right now as the difference is there. But coming to what is being more talked about right now, and was a big part of the SABCS, was the use of ovarian function suppression in patients that are premenopausal. And I'll briefly talk about the text and the soft trials and the various changes that we have seen in the results of these trials across the last 12 or 13 years. Basically, the topic that was given was randomized comparison of adjuvant aromatase inhibitor, exemestane plus ovarian function suppression versus tamoxifen plus ovarian function suppression in the premenopausal women who have hormone receptor positive early breast cancer. So all of us are aware that premenopausal women with early breast cancer do poorer as compared to our postmenopausal patients, and they are at an increased risk of disease recurrence. We also know and recognize that adjuvant endocrine therapy is the cornerstone of treatment for those patients with endocrine sensitive premenopausal early breast cancer. Up till a few years ago, based on the EBCTG meta-analysis, all of us were using tamoxifen for 5 years as the standard of care. And later, of course, there were some updates on using extended tamoxifen for 10 years. But most of the data or the evidence in support of this comes from these analysis of that showed that use of tamoxifen in ER-positive breast cancer was very effective in premenopausal patients. Especially here, we can see that those who had fought less than 45 years and received tamoxifen versus not, we have a 15-year gain of 12.6% in recurrence and a 10.6% gain in breast cancer mortality. So prior to the soft and the text trials, we all accepted tamoxifen as the standard of care. We did not know the value of ovarian function suppression for women who were receiving tamoxifen. We also recognized that patients who had chemotherapy-induced amenorrhea had a reduced risk of relapse. However, the likelihood of chemotherapy-induced amenorrhea was less common in patients who were less than 40 years of age. And of course, there was no data on the use of aromatase inhibitors in premenopausal women. So the questions that we were looking to have answered from these trials is there a role of ovarian function suppression for women who remain premenopausal and are treated with tamoxifen? And is there a role of the use of aromatase inhibitors in premenopausal women when treated with ovarian function suppression, given the benefits of aromatase inhibitors in our postmenopausal patients as compared to tamoxifen? We are all aware of the mode of action of the LHRH agonist in breast cancer. We know that tamoxifen blocks the estrogen receptor and it reduces the mitogenic effects of estradiol and decreases cancer cell growth and proliferation. And the AIs reduce production of estrogen by suppressing the activity of aromatase and enzymes. The problem in premenopausal women is that there is a large amount of ovarian estrogen production from the ovaries, which is shut down in postmenopausal women. And therefore, they are under a strong influence of the pituitary gonadotropins. If you use AI alone, it increases GnRH, gonadotropin release and promotes estrogen-dependent aromatase activity. Therefore, it counteracts the effectiveness of AIs because they are unable to decrease the all of the estrogen that is available periphery. So prior to this, the use of AIs were of very limited benefit as they were not able to reduce the circulating estrogen in a significant way. So coming to the text and the soft trials, we'll go over the outline of the studies. Text was, enrollment was over 8 years from November 2003 and to 2011. This looked at premenopausal women with endocrine responsive early breast cancer. They were to receive ovarian function suppression from the start of adjuvant therapy, which means they were randomized within 12 weeks of surgery. On the basis, they were stratified whether chemotherapy was planned, not planned. So basically, these were the patients who got ovarian function suppression, even if they were getting chemotherapy. And there were two arms, tamoxifen versus ovarian function suppression, which was with triptorelin, and exemestane was with ovarian function suppression. The soft trial was a little bit different, as in there were 3 arms. Again, the patients were stratified based on the use of chemotherapy, nodal status. The target in this was about 3,000, but here the patients were either randomized within 8 months of the final dose of chemotherapy, or if they were not receiving chemotherapy, they were randomized within 12 weeks of the surgery. A little talk about the ovarian function suppression and the way it was given in these trials. All the trials were for 5 years, duration from randomization. Tamoxifen, all of us used 20 milligram per day, exemestane 25. In text, all the patients started ovarian function suppression with triptorelin that was given monthly, because we are aware that when we give the 12 weekly dose, there is a little bit of escape. And they were given triptorelin for at least 6 months, after which the patients could opt to undergo oophorectomy or ovarian irradiation. In soft trials, the use was of either triptorelin, oophorectomy, or ovarian irradiation by patient preference. And once the patient started triptorelin, they could undergo bilateral oophorectomy or irradiation at any time. We have to remember, if they are undergoing oophorectomy, it takes almost 6 weeks for the hormone levels to fall. So usually we should start the exemestane 6 to 8 weeks after the oophorectomy. So looking at the number of patients in the trials and the way we were trying to answer the questions, the first question was, is there a role of AI? So we looked at tamoxifen plus ovarian function suppression, patients in both text and soft, versus exemestane plus ovarian function suppression. When we wanted to answer the role of whether there was a role of ovarian function suppression, we are looking in the soft trials in the 2 arms of tamoxifen versus tamoxifen plus OFS. So the first publication came out in 2014 and published in NEGM. And this was at a median follow-up of about 5.5 years, 68 months. And here we are able to see clearly that looking at tamoxifen with ovarian function suppression versus exemestane plus ovarian function suppression, there is a 4% survival, disease-free survival advantage in favor of exemestane. That was significant. When we look at freedom from breast cancer also, we can see this 4 percentage point difference in favor of exemestane with ovarian function suppression versus tamoxifen with ovarian function suppression. When we look at the freedom from recurrence at a distant site, the difference starts to fall, and it's about 1.8%. And here, as is clearly delineated, there was no difference in overall survival. So the difference is there in disease-free survival in breast cancer recurrence at a distant site, but nothing in favor of overall survival advantage of the use of AI with OFS versus tamoxifen with OFS. In the authors' discussion, they talked clearly that exemestane with ovarian function suppression versus tamoxifen with OFS significantly improved in favor of exemestane and OFS disease-free survival, lengthened the time without breast cancer and time without distant recurrence. The risk reduction was about 28%. And we know that even in the postmenopausal women, this is kind of, the hazard ratios have been in the range of, 0.74 to 0.68, something like that. So kind of similar to what we see in the postmenopausal patients, and 34% risk reduction in the risk of breast cancer recurrence. In the soft trials at this update, the tamoxifen versus tamoxifen plus OFS did not show even a difference in DFS. Although it showed that patients getting adjuvant chemotherapy, there was a slight favor of ovarian function suppression. And this is at that 5.5 year mark. Coming to, again, the 8-year mark. This is the 2018 publication, again, from NEJM. So here, the median age of patients receiving chemotherapy was lower, 40 versus 46, those not receiving chemotherapy. Node positive patients was about 1/3, and majority, about 85%, had HER2 negative tumors. And looking at the entire cohort, when we look at tamoxifen versus tamoxifen plus ovarian function suppression versus exemestane plus ovarian function suppression, when you compare tamoxifen to tamoxifen plus OFS, there is a 4% difference in favor of tamoxifen plus OFS in disease-free survival. And those patients who got chemotherapy, there was a slightly larger difference of about 5%. When we look at exemestane plus ovarian function suppression versus tamoxifen, the difference is 7%. And in patients who got chemotherapy, it's about 9%. So again, here we see that there is an advantage to using ovarian function suppression as compared to tamoxifen alone in regards of disease-free survival, which means local, regional recurrence, contralateral breast cancer, and distant recurrence. And we know that patients who have contralateral breast cancer or local recurrence, they are patients who can still be cured, but there is significant morbidity involved in these patients. And that may be one of the reasons why it does not reflect so much on the overall survival. When we look at the subgroup analysis, a little surprising here, they showed that there was a greater benefit of using ovarian function suppression with tamoxifen versus tamoxifen alone in patients who had HER2 positive disease. Here the patients, the authors kind of talked about how in 2003, use of trastuzumab may not have been that, that widespread. And because this was a very old trial, we are talking about 20 years ago. And they alluded to one that may be one of the factors why, using the OFS, using ovarian function suppression may have proved to be better. But by and large, we can see in this forest plot that there is a favor of tamoxifen plus OFS versus tamoxifen. When we look at exemestane plus ovarian function suppression versus tamoxifen alone, again, we can see that majority of the hazard ratios are in favor of exemestane, and especially in patients who were HER2 negative, which we remember is the majority of the patients, and those who got chemotherapy, the absolute difference almost came out to 11%. So a significant disease-free survival advantage for the use of exemestane plus ovarian function suppression. Again, little surprising results in the overall survival at 8 years. They showed like a 1.8% survival difference in favor of tamoxifen plus OFS versus tamoxifen alone. That was significant, but there was no significance in exemestane plus ovarian function suppression versus tamoxifen. Again, this is something little confusing when we see such distinct advantages in disease-free survival, but it does not seem to translate into overall survival. Or it may be that, we haven't followed these patients long enough, which could be because the results are so good, even at 8 and 10 years, we will see. So here we see that there is not that it's not significant. When we compare at this point exemestane plus OFS versus tamoxifen plus OFS, we can see there is a 4 percentage point difference in 8-year DFS in favor of exemestane plus OFS. In the freedom from distance recurrence, it is a 2.1% difference, but overall survival difference, again, is not able to be demonstrated. In the HER2 negative population, the disease-free survival advantage seems to be higher, both in disease-free survival, 5.4%, and freedom from distant recurrence. Instead of 2%, it comes up to 3.5%. Again, 85% of the population was HER2 negative. In the subgroup analysis, we can see that this translates through. HER2 negative had significant disease-free survival advantage when use of exemestane plus OFS. Patients who received chemotherapy also, we can see the hazard ratio is significantly in favor of exemestane plus OFS. And it translates again for distant recurrence also. But when you look at the hazard ratio for the overall survival, we can see that it crosses 1. So unable to prove that there is a survival advantage of using AI plus OFS versus tamoxifen plus OFS. Things to think about, that there was early discontinuation that was highest in the exemestane plus OFS arm. And if we compare exemestane plus OFS versus tamoxifen plus OFS, we can see that there is almost a 4 to 5% difference. Grade 3 adverse events were higher, again, in those patients who got ovarian function suppression, and especially those who got exemestane plus ovarian function suppression. Much more musculoskeletal adverse events. And all of us are quite familiar with all of this in our postmenopausal patients. There is more osteoporosis, 14-15% in the exemestane plus OFS. We know that vaginal dryness and dyspareunia become problems. And we also know that ovarian function suppression leads to other comorbidities. There is more hypertension, more glucose dysregulation, etc. in patients who receive an AI with OFS. So on longer follow-up at 8 years, while there was no difference in tamoxifen versus tamoxifen OFS. Now we are seeing a difference even with tamoxifen with OFS. We are seeing again 24% lower relative risk of recurrence, second invasive cancer or death. And the absolute difference we have already talked about is there, 4% with tamoxifen plus OFS and 7% with exemestane plus OFS. So the questions that we need to ask ourselves is, and again, we can get into this. Should all patients who are premenopausal hormone positive, should all of them be getting ovarian function suppression? The relative treatment effects are similar regardless of chemotherapy, but the absolute benefit seems to be in favor of those patients who remain premenopausal after chemotherapy and have the highest risk of recurrence. So when we are evaluating our patients and considering adjuvant endocrine therapy and the use of OFS in these patients, the questions that we probably need to ask ourselves is, look at the clinical pathological features, look at the age, are they less than 40, less than 35, and look at their HER2/neu status, because we have clearly seen that those who are HER2/neu negative and receiving chemotherapy, the advantage of using ovarian function suppression is quite significant. And there was a very interesting side paper that came out from this. It was published in JCO, and that looked at all of these clinical pathological features. And here we can see, when we look at the curves, that definitely for patients who are less than 35 years of age, there is significant difference in the 8-year survival free from disease recurrence as compared to those who are over the age of 50. There is a difference in those who have more than 4 positive lymph nodes. There is a difference in patients who have tumor size more than 2 centimeters. For those who have a high versus low ER expression, again for the progesterone receptor expression. For patients who have a higher grade, we know that the disease-free survival, the risk of disease recurrence is higher. We know that those who have a higher Ki-67, and in this they showed more than 26 versus less than 14, the difference is almost 14-15%. So you have to weigh the pros and the cons, because as of today, we still do not categorically can say that there is a difference in overall survival. And again, in the SABCS update, the authors talked about how following these patients for another 5 years, which makes it almost 25 years, we might see an overall survival benefit. In SABS, they also had a 2021, they had a 7,000 patient meta-analysis, and they looked at all the 4 trials, the SOFT, the TEX, the HOPE, and the EBCTG. And in that, they also showed that there was significant difference in disease-free survival benefit for the use of exemestane plus OFS as compared to tamoxifen alone. And the difference with exemestane plus OFS was about 15%, and difference with tamoxifen plus OFS was about 10%. So I guess both of these are very valid options. We know that recurrence leads to greater effect of quality of life, both personal and family fulfillment, and is associated with substantial economic burden for those patients who relapse or have a contralateral breast cancer. But at the same time, we have to talk about the increased rates of acute and late toxic events. And in individual patients, it is we end up talking and weighing the side effects, the effect on the quality of life. And it is a very difficult discussion, because when you talk to a 35-year-old that, we are going to make you postmenopausal now with the use of these drugs. And now more and more we are talking to our patients who have a higher lymph node burden, have received chemotherapy about this. It's a difficult conversation, and most of them are unable to understand the long-term implications and, how it may affect their quality of life. So it's a difficult decision and a difficult conversation for the physician also. Again, talking about the update of 2021, which is the 12-13 year follow-up, one of the things that was highlighted in this is that patients who are at low risk and who have not received chemotherapy, the 12-year overall survival is more than 95%, regardless of the endocrine strategy you use. So for those patients, I probably, and the authors and the presenter also said that those patients, you don't need to consider ovarian function suppression, and it supports the use of tamoxifen alone. And they did, of course, talk about that relative risk reduction in distant recurrence and death persists with longer follow-up for our high-risk patients. And in those patients, ovarian function suppression, whether you use exemestane or tamoxifen, there is an absolute reduction that is significant, but you have to select your patient appropriately.
You're just left with 1 minute to conclude your presentation.
So I'm concluding.
Thank you.
The absolute difference is about 1.8% at 12 years. And AI versus OFS versus T versus OFS, it is significant. When we look at the chemotherapy alone arm, there was a 3.3% difference in favor of aromatase inhibitors, that is the exemestane. Patients less than 35 and those who receive neoadjuvant chemotherapy benefited the most from ovarian function suppression. And of course, we also know that this has now been included in the NCCN guidelines as a category 1 recommendation and something to talk to our patients when we come to the point of talking to them about adjuvant endocrine therapy. And with that, I will thank you all for very patient listening. Thank you.
Thanks a lot, Dr. Anubha. Yes, it was surely a patient listening. I don't know how much patience you had to make this presentation. At end of the slide, I was still remembering what is the topic. It was so exhaustive, very exhaustive, and actually
I think
the
bottom line is that the bottom line that I got from all of this and reading, I've been like trying to read, the experts and listen to what they are saying, because it's very confusing. If you tell a patient there is a difference in disease coming back, but it's not going to impact your overall survival, they get confused. They're like, what are you talking about? And then you give them the XYZ side effects. I tell you, this is a very difficult conversation. I have started to have it with my patients and I welcome what you guys are doing. But this alone, talking about this takes up half an hour to tell the patient about ovarian function suppression. So it's a very difficult conversation. And, we have to be convinced before we tell our patient that go ahead and do this.
Yes.
Absolutely.
That is the main problem.
Yeah.
And you say for 5 years, you have to give them a medicine
Yeah.
which may or may not be effective. And then, of course, the bottom line is you have to choose your patient. High risk patients are there. You don't want them to get back disease. Overall survival is all right, but recurrence means something to the patient. We maybe local recurrence do something, but if it is a distance recurrence, the story is over for the patient. So it is important that we choose the right kind of patient to give this. And don't go overboard with this for 5 years. So much toxicity associated with it.
Yeah.
Wonderful topic, and I was wondering how we will proceed, but fantastically you have given us even the minor issues which were there.
Yes. So next we will go for the new talk in the town. You can say abemaciclib in early breast cancer adjuvant therapy, and it will be presented by Dr. Rajiv Saini, consultant medical oncologist in Shri Mata Vaishno Devi Narayana Hospital, Jammu. Over to you, Dr. Rajiv.
Thanks, Dr. Gautam. Thanks, Rajeshwar sir, and thanks for giving me the opportunity to speak on this very relevant topic. I hope I am audible to everyone.
Yeah, audible. Make it on PowerPoint, please.
Okay, sir. So, is my slides are visible?
They're not on PowerPoint. They're visible otherwise. You can proceed like this also.
Sir, are they moving? Okay.
You're on second slide.
Are they moving, sir?
No, they are not.
Yes, sir. Please. Okay, sir.
Dr. Sani, I think, I faced this problem. You have to stop screen share, open the slideshow, start your slideshow, then come back to screen share. If you open it in PowerPoint and then start screen share and do slideshow, it doesn't work.
Okay. Okay, so the topic which was given to me is role of abemaciclib in adjuvant setting. So this is the Monarch E trial where the abemaciclib was being compared against, along with adjuvant endocrine therapy, was compared against adjuvant therapy alone in patient with high risk hormone positive, HER2 negative early breast cancer who received prior neoadjuvant chemotherapy. Basically, this is subgroup analysis. Otherwise, the trial is comparison of abemaciclib plus adjuvant endocrine therapy against adjuvant endocrine therapy alone in patient with high risk hormone positive, HER2 negative early breast cancer. As we know, the first drug which was approved in adjuvant setting was tamoxifen. Then AIs were approved, and then now a few years back, on the basis of soft and text trial, ovarian suppression therapy was also added along with the tamoxifen or AI in adjuvant setting. Now we have seen that many patients diagnosed with hormone positive, HER2 negative early breast cancer will not experience recurrence with standard therapy, but 20% of patients may experience disease recurrence or distant relapse in the first 10 years. Risk of recurrence is higher for those with high risk clinical or pathological feature, especially during the first few years on adjuvant endocrine therapy. So there was need of some novel treatment which can prevent early recurrence and distant metastasis. Now, abemaciclib, which is an oral continuously dosed CDK4 and 6 inhibitor, is approved for HR positive, HER2 negative advanced breast cancer in combination with endocrine therapy. So they were approved with fulvestrant, and with which overall significant overall survival was significantly improved. And based on efficacy and safety data in the metastatic setting, this drug with endocrine therapy is being explored in adjuvant setting. Now, the background of this trial: patients with hormone positive are at early breast cancer at higher risk of recurrence have an ongoing need for enhanced adjuvant endocrine therapy that can improve limited outcome associated with current neoadjuvant chemotherapy. So in this trial, in this subgroup analysis, I'm talking only about those group of Monarch trial where neoadjuvant chemotherapy was given upfront. Otherwise, the whole group is high risk patient, irrespective whether they have received chemo in adjuvant therapy or neoadjuvant setting. So we are discussing here only those group of patients where the neoadjuvant chemotherapy was received upfront. So in this phase 3 Monarch trial, addition of CDK4/6 inhibitor abemaciclib to adjuvant endocrine therapy significantly improved invasive DFS and distant recurrence-free survival versus endocrine therapy alone in patients with high risk HR hormone positive, HER2 negative early breast cancer. In the primary outcome analysis, IDFS HR was 0.713 and distant RFS HR was 0.687. And so the current report presents efficacy and safety result from outcome analysis of Monarch E trial for patients who received prior NAC. As such, FDA has approved abemaciclib on the basis of Monarch E trial in a specific group where Ki-67 is more than 20%. So this was at present, this is the only approval by FDA on the basis of Monarch trial. Now, what in this trial we are discussing, we going to discuss about those subgroup where neoadjuvant chemotherapy was given upfront. So this is the standard study design of this trial, where women or men with high risk node positive, hormone positive, HER2 negative early breast cancer were permitted pre or post menopausal, no distant metastasis, and less than equal to 16-month home surgery to randomization, or less than equal to 12 weeks of endocrine therapy after last non-endocrine therapy. Now they have basically what are high risk patients which were included in this monarchy trial. These were those patients who are N2 disease, that is more than 4 positive lymph node, or 1 to 3 positive lymph node, along with either they were histologically grade 3, or the tumor is more than 5 centimeter, or the patient have Ki67 more than 20%. So then they again divided this high risk patient into two cohorts. In cohort 1, these are slightly at more higher risk as compared to cohort 2. In cohort 1, more than 4 positive lymph node, or 1 to 3 positive lymph node with grade 3 histology, or tumor with more than 5 centimeters. And in cohort 2, the second group, that is 1 to 3 positive lymph node with Ki67 more than 20%, irrespective of tumor size. That tumor size should be less than 5 centimeter, and grade should not be 3, but Ki67 should be more than 20%. So these are the cohort, and they were randomized between abemaciclib 150 milligram twice a day up to 2 years, and endocrine therapy per standard of care of physician choice versus endocrine therapy alone. So the primary endpoint was invasive disease-free survival, which was primary outcome, and primary outcome analysis occurred after 395 events in intention to treat population. And the key secondary endpoint was distant recurrence-free survival and IDFS in Ki67 high population. So this is the basically group that is high, Ki67 high, more than 20% population, where this drug was approved by FDA in last year in October. So if we see the neoadjuvant subgroup, what are the drugs which was received? So majority of the patient, that is around 90% of the patient, had received both the active agent, that is anthracycline and taxanes, while other around 7% of patients received anthracycline without taxane, and around 3% of patients only received taxane plus cyclophosphamide in neoadjuvant setting. So if we see the patient characteristic in both the group, they are well matched, but a greater population of patients in the neoadjuvant subgroup were premenopausal and had larger radiological tumor size at diagnosis. So if we see the primary endpoint, that is invasive DFS, in the neoadjuvant group, abemaciclib plus endocrine therapy demonstrated a clinically meaningful, that is 38.6% reduction in risk of an IDFS event versus endocrine therapy alone. And the 2-year IDFS rate was higher with abemaciclib versus endocrine therapy alone in the neoadjuvant group. That is absolute benefit of 6.6% in the primary endpoint. And regarding distant recurrence-free survival, also abemaciclib demonstrated a clinically meaningful 39% reduction in risk of distant RS recurrence-free survival event versus endocrine therapy alone, and there was absolute benefit of 6.7%. So if we see the subgroup analysis, that is, if it has been seen that tumor size, which was a potential prognostic factor at diagnosis and at surgery after receiving of neoadjuvant therapy. So the abemaciclib reduced risk of IDFS and DRFS even independent of tumor size at diagnosis or at surgery. So regarding the adverse events, as we know, the safety profile in neoadjuvant group subgroup consistent with the overall safety population and is established safety profile of abemaciclib. So as we have seen in metastatic setting, also the main side effect of the abemaciclib is diarrhea, which can be easily managed by dose reduction or temporary withholding of the drug. So the conclusion of this subgroup analysis is that in this pre-planned subgroup analysis of monarchy trial, abemaciclib plus adjuvant endocrine therapy demonstrated clinically meaningful improvement in invasive DFS and distant recurrence-free survival versus endocrine therapy alone in patients with high risk, hormone positive, HER2 negative early breast cancer who received prior neoadjuvant therapy. Reduction in IDFS risk is around 38%, and distant recurrence-free survival is around 39%. benefits were numerically greater than those observed in interaction population, were maintained independent of tumor size at diagnosis and surgery. Among those treated with endocrine therapy alone, the NAC subgroup exhibited a lower 2-year DFS rate versus the intention to treat population, consistent with a high risk of recurrence. 2-year IDFS rate comparable to that reported in the control arm of phase 3 Penelope B trial, which compared palbociclib versus plus endocrine therapy versus placebo plus endocrine therapy in women with high risk hormone positive HER2 negative endocrine breast cancer after neoadjuvant therapy, and the safety profile in this population is consistent with prior report from abibaciclib. Thank you.
Thanks a lot, Dr. Rajiv. Can we go for the next section? Next is
we have 10 minutes to this. I think experts and presenters are required to clarify a few things. Firstly, I mean, what is your opinion on the first, that is whether to go for TAC or now AC is equal to TC, and AC followed by T is inferior to TAC. So how do you plan to go about treating your patients now? Dr. Javed, do you have any comment?
Okay.
Yes, sir. Since practice has changed
slightly louder, please.
So we don't do this practice of TAC. So I don't know whether we should go with this or not. But definitely in patients who have high risk hormone positive disease, that's more node positive, IKI67, T7. So definitely this becomes an evidence in terms of to decrease the recurrence and improve the mortality. So I don't know. I have never done this kind of practice to give TAC versus only this one concurrent sequential.
But you are justified in using TC only in patient who have to. Otherwise, you give AC followed by T.
Yes. That paper came after this paper. That has been published in January 2022, this year only. That they have seen their those who have early breast cancer with less nodal disease, that means N1 or N0, they were benefited with TC. There was no improvement with the addition of the anthracycline. But those who had N2 or N1 disease or N3 disease, they benefited with the anthracycline. But the benefit was also marginal.
So basically, basically it is a high risk that we have to change slightly. And anybody for adjuvant abemaciclib in their practice, anybody following it?
Sir, I have a question that all the three drugs have been tried in the adjuvant setting. Palbociclib failed, ribociclib failed, and only abemaciclib has shown some benefit. So is it just like that that you are doing, there is a group of drug of CDK inhibitors, you are doing a subgroup analysis, and one of the drugs is positive. So are we actually right in writing abemaciclib in these type of patients when we know that, okay, I go other way around. If abemaciclib is of 2 lakh rupees and ribociclib is of 10,000 rupees, both have shown a benefit, or abema has only shown a benefit, we will easily use ribociclib. Like we are using rucaparib in patients after first line, as compared to it hasn't shown any benefit. कि वो same group of drugs हैं, we can replace rucaparib for olaparib. Similarly, we are using the
sorry. You see, science in probably oncology, the problem is 2 plus 2 generally not always 4. It can be 5 and it can be 3 also. I've faced this problem today itself. A person who's got a empanelment, and he comes with this question to me. So I'm still struggling with my answer whether to give her a toxicity, but she's read about it. And firstly, she was annoyed that immunotherapy was not given to a triple negative, which we'll discuss. And subsequently, she says you're not giving this drug also. Now, what answer I have?
So
How will you justify?
I think when we talk to Dr. Gautam Goel's question about whether these drugs are interchangeable, I think abemaciclib is a little bit different from the other ones because we know that abemaciclib has single agent activity also, which the other two drugs don't have.
Yes, in relapse, yes.
And especially in like multiply treated, so maybe that's where that little bit of difference comes about, is that it is a little bit different from the other two agents. And especially in this situation, probably in the adjuvant setting, one should not replace, but I agree in the metastatic setting, all of us replace. I mean, we go for the most cost effective when the patient asks us, but probably in this setting, for whatever reason, or whether the drug is a little bit different, that there isn't, we cannot replace.
So these were three difficult, it looks easy, all these three topics, but they are actually not very easy to answer, give all the answers to a patient. Some educated patient will come and question you on this, that he's read about this and this. So that is why I try to put this day-to-day practical issues in this.
And you're right, they get annoyed if you don't offer it to them. And retrospect,
exactly.
You're like, okay, I should have talked about it.
And say even 5 years thereafter he gets a recurrence, he's going to blame you on this. You didn't start. Maybe the next data is very strong. He said that available evidence was there. FDA is approved. What was your problem in not giving me this drug? So thank you, Dr. Gautam. That was a wonderful expertise of yours in managing this. Now we come to the next session is basically Roche sponsored session where Dr. Gautam will again present a continuum of care in HER2 positive early breast cancer. Dr. Gautam, please.
Yes, sir. So good evening, everyone. My topic for presentation. Am I audible?
Yes, your slides are also visible.
So my topic for presentation today is continuum of care in HER2 positive early breast cancer. And I managed to make few last minute slides. As we all know, HER2 expression is a negative predictive as well as prognostic factor in breast cancer. It is associated with disease recurrence, metastasis, as well as shortened survival. And HER2 overexpression is seen in near about 20% of all of the breast cancer patients. And 1 in 4 patients of HER2 positive breast cancer will have a disease recurrence or death in spite of all the treatment which we give them. So there is a unmet need, or you can see there is a need where we can increase our effectiveness by near about 25% in this set of patients. Then the second concept is neoadjuvant therapy. Initially, the neoadjuvant therapy was used for the patients with inoperable or locally advanced cancers which were not amenable to surgery upfront. So we used to give chemotherapy or endocrine therapy so that the tumors reduce in size and they become operable. But now we are using the neoadjuvant therapy in inoperable as well as locally advanced tumors as well as operable breast cancer which have a high risk of recurrence depending upon the characteristics of the tumor. We are using targeted therapies, chemotherapy, and we try to modify our treatment depending upon the results of the initial, that is neoadjuvant therapy. The example means that we are trying to use this neoadjuvant therapy, see the response to this neoadjuvant therapy, and the subsequent therapies are dependent upon the response to the initial neoadjuvant therapy. This has been used in triple negative breast cancer where we initially used to use sandwich therapy, or we used to operate first. Now we go all of the therapy, that is anthracycline as well as taxanes upfront. And if the patients do not achieve a PATH CR on surgery, we give them the adjuvant capecitabine and it has shown a better survival. Similarly, in HER2 positive breast cancers, as we will see that we are using adjuvant TDM1 in patients who did not get full response to the initial therapy. So response adjusted therapy is the benefit of new adjuvant therapy, or you can say subsequently PATH CR. So first, HER2 positive therapy in new adjuvant chemotherapy in HER2 therapy. So first was the NOAA study, where we, in stage 3 breast cancers, patients were randomized to receive chemotherapy versus chemotherapy plus trastuzumab, and then later followed by surgery. The main effect was that the PATH CR, the pathological complete remission, increased from 25% to near about 60 to 65% in patients in which we added trastuzumab to the chemotherapy regimen. So in this study, we were able to see that addition of trastuzumab added to PATH CR as well as added to increased overall survival as well as increased event-free survival. Now, from these type of studies, it came that the PATH CR can act as a surrogate marker to look for the early effectiveness of any type of therapy. I am saying that it can act as a surrogate marker. It is not a definitive surrogate marker that it will land into a long-term survival benefit, but it is being taken as a surrogate marker so that we can manipulate and we can manage as well as select better studies as well as the better drugs. Now, how can we improve this PATH CR? For the HER2 positive tumors, it comes as a dual anti-HER2 therapy with the addition of pertuzumab, which binds to a HER2 receptor but at a different domain as compared to the trastuzumab, and it helps to have a better results along with combination of with trastuzumab. So the first came the Neosphere study. It was a phase 2 study in which HER2 positive patients were randomized into 4 arms: chemotherapy plus trastuzumab, chemotherapy plus trastuzumab plus pertuzumab, only trastuzumab plus pertuzumab, and chemotherapy plus pertuzumab. And what we saw that there was 45% pathological complete response in a patients who received docetaxel plus trastuzumab plus pertuzumab. And those patients, out of these all patients, those patients who received PATH CR had a better overall PFS benefit up to 5 years as compared to those who don't achieve the PATH CR. This means that those who don't achieve the PATH CR were biologically bad tumors, one thing, and secondly, achievement of PATH CR can again act as a surrogate marker to look for the effectiveness of the therapies. So this combination of neoadjuvant pertuzumab and trastuzumab plus docetaxel improve the long-term outcomes. With the analysis of the patients who achieve PATH CR has a reduced risk of PFS or DFS as compared to those who didn't achieve the PATH CR. Then came the Trifina study, again in the neoadjuvant setting. Here again the combination was pertuzumab plus combination. The one arm was docetaxel, the other arm was 3-cycle FEC followed by docetaxel along with pertuzumab in all the cycles. In the third arm, only FEC was given for the initial 3 cycles to look for the cardiotoxicity, and the subsequently 3 cycles were given with docetaxel, and this was followed by surgery and followed by trastuzumab for the 1 year. The primary endpoint was to look for the cardio safety of these combinations along with anthracyclines, symptomatic left ventricular systolic dysfunction, and ejection fraction decline of more than 10%. Secondary endpoint was PATH CR as well as the rate of breast conservation surgery. With these, it was seen that the docetaxel, carboplatin, and pertuzumab trastuzumab arm has the maximum PATH CR, near about 65 to 66%. Secondly, the PATH CR was better in the arms where the hormone receptor negative tumors were there as compared to hormone receptor positive tumors. So also the results from this study indicate a low incidence of symptomatic as well as asymptomatic left ventricular systolic dysfunction across all arms during the new adjuvant as well as the adjuvant trials. So it also emphasized that concurrent administration of pertuzumab plus trastuzumab along with anthracycline resulted in similar cardiac tolerability compared with sequential administration or the anthracycline free regimen, the docetaxel, carboplatin, pertuzumab and trastuzumab. Now we jump over to the adjuvant. In affinity, the pertuzumab and trastuzumab, the patients were upfront operated. They received chemotherapy plus trastuzumab plus Perjeta versus placebo. The 5-year, near the 6-year risk of recurrence, there was a benefit of 2.8% in the combination arm where we have used pertuzumab, and it node positive patients, this benefit extended to 4.8%, but this benefit was seen in all near about all the subgroup, but the overall survival benefit was only 0.9% in patients where pertuzumab was used in addition to the standard chemotherapy plus trastuzumab. No new cardiac safety problems. The cardiac events to the tune of 0.8% in the patients who received combination of pertuzumab and trastuzumab, and secondary cardiac events were near about to the tune of 2.5 to 2.7%. No difference in quality of life on addition of pertuzumab. Now comes the Catherine trial. So Catherine trials is on the same basis of the CreateX trial, where you use all the best drugs upfront, see the response to that drugs, and depending upon the response to those drugs, you modify the further treatment. So the study rationale was that the patients who received total path CR versus no path CR, the event-free survival as well as the overall survivors are less. So it is on the same policy of CreateX as in triple negative breast cancer. So the study arm was like in newly diagnosed HER2 positive patient, those who received the new adjuvant with trastuzumab, pertuzumab and chemo after surgery, whether they have a residual disease or path CR, they used to get trastuzumab, pertuzumab plus chemo depending upon the basis of affinity trial. Now, in this study, those patients after surgery has a residual invasive tumor, they were randomized to receive trastuzumab, that is the standard, versus TDM1, that is the Kadcyla. The only problem is this, that they have not randomized any arm with trastuzumab plus pertuzumab. Maybe at that time trastuzumab plus pertuzumab was not the standard of care when this study was going on. So that is the reasons trastuzumab was standard, they randomized trastuzumab versus Kadcyla. The primary endpoint was invasive disease-free survival, and there was other endpoints like OS, DFS as a secondary endpoint. The primary analysis, the invasive disease-free survival at 3 years was near about 11% better in the TDM1 group, those patients who received TDM1 as compared to trastuzumab. Now this is what we are looking at on the left side of your screen on yes. So if you are using trastuzumab only in a patients as a new adjuvant therapy, that is trastuzumab plus chemotherapy, the baseline IDFS at 3 years is near about to the tune of 76%. And if you use Kadcyla in the adjuvant setting, this improves by near about 12%. As compared to the right side, if you use pertuzumab with trastuzumab in the new adjuvant setting, the baseline invasive disease-free survival is near about to the tune of 81%, and over and above, if we use TDM1, it increased to 91%. So both the patients, whether we have used new adjuvant pertuzumab plus trastuzumab, the benefit is to the tune of 10.5% in invasive disease-free survival. And whether we have used only trastuzumab, then also if this approach is followed, it increases to the tune of, the benefit increases to the tune of 12%. This is the first interim analysis. Fewer distress recurrences as compared to trastuzumab in Kadcyla group, that is near about 78 as compared to 121 at against a total in both the groups the total number of population was 743. Yes, the OS results are still immature, and the p-value of this is coming about 0.08, not statistically significant yet, but let's see when it gets mature. So other secondary efficacy endpoints, IDFS including secondary primary non-breast cancers better in the TDM1 group as compared to Herceptin only, and similarly disease-free survival. So the efficacy summary of TDM1 reduced the risk of invasive disease-free survival even by 50% compared with Herceptin when used in the adjuvant setting in the patients who have not received PAT-CR with the new adjuvant chemotherapy plus trastuzumab plus pertuzumab. And the 3-year IDFS increased near about 11% from 77 to 88%. So post-Catherine, now it is that for newly diagnosed high-risk HER2 positive breast cancer, early breast cancer, the new adjuvant therapy should be used pertuzumab, trastuzumab plus chemotherapy, docetaxel and carboplatin, and surgery. And if there is a residual disease, TDM1 should be used. And if there is a PAT-CR, I still go for trastuzumab only. I don't know whether we can use trastuzumab plus pertuzumab because the benefit is of the tune of 0.9% at the 6 years. These all regimens have been taken up with the NCCN also. And this is the AGO guidelines, which has shown that if it is a clinical T1 and N0 tumor, so if it is a clinical T1 N0 tumor, you can go for an upfront surgery. And if it again comes out to be PT1C N0, you can use trastuzumab with paclitaxel. If it comes out to be T2 N0 or N+, then you can use trastuzumab based therapy plus neratinib. I was not able to cover neratinib in my discussions. And if it comes out to be node positive, you can use pertuzumab and trastuzumab. If you have used pertuzumab in the adjuvant setting, you don't know whether there is any benefit of adding neratinib or not. And if you are using in small tumors also, if you're using new adjuvant taxanes plus trastuzumab, and if there is a PAT-CR, only trastuzumab is sufficient. If not PAT-CR, you can use pertuzumab as well as trastuzumab. And in the patients who have a T2 tumor or node positive, yes, pertuzumab plus trastuzumab should be used. I have used in quite a few of patients, and leaving aside one patient, all patients had a PAT-CR followed by surgery. And if non-PAT-CR, then I think TDM1 should be the choice. Thank you. I was not able to cover neratinib because of some occupancies. I'm not able to make. Sorry for that.
Cancer treatment as far as the HER2 breast cancer is concerned. So my only question is, how do you practically, discussion is all right. How do you treat your, in practical terms, HER2 positive breast cancer at this moment? High risk, say, clinically starting from new adjuvant.
So we are giving them the option of this drug, pertuzumab. If my patient is totally fit patient, I plan with docetaxel, carboplatin, trastuzumab, and pertuzumab. And after 6 cycles,
here my question is slightly different. You use paclitaxel only, or toxicity? How much toxicity you get with docetaxel compared to weekly paclitaxel with these three combinations?
So docetaxel is a very difficult drug, and especially in this setting, docetaxel carboplatin with these two agents, it is a difficult drugs. And if you say I have used this combination in 10 patients, and out of 10 patients, 3 patients after our second cycle, they were not able to tolerate, and I have to shift them to weekly. Those who were fit at baseline, I shifted them on weekly paclitaxel. And those patients who are in the initial phase to look that they will not tolerate docetaxel, I start with weekly paclitaxel plus trastuzumab and pertuzumab.
So, I mean, this is a practical issue, for all people who are listening, that preferably there is no harm in starting with paclitaxel as compared to docetaxel. And subsequently, say post surgery, how do you plan this thing? Same, you give Kadcyla to non-PACR.
Yes, sir.
Okay.
So I will say that I have used only in one patient. I have advised TDM1. Otherwise, in all the patients, it was a beautiful PACR, sir.
Okay. So if there is a PACR, you don't go for, you go only for trastuzumab, or you give both Perjeta as well as if you are given before? I'm just trying to bring out the positive points in your discussion only, what you do, and people are listening to it. They will
Yes. So I am giving only trastuzumab in the patients who achieve a PACR, sir. Because there is no data of using trastuzumab, pertuzumab in new adjuvant and then followed by adjuvant also, sir.
Okay. And then you followed for how many cycles? If you have to use both the combination, you are following standard 1 year. This thing? Adjuvant.
I have not used adjuvant. I have not used, sir. Adjuvant. I have not used.
Okay. So thank you, Dr. Gautam. That was a lovely presentation. And now we proceed on to the next, that is a triple negative breast cancer. Again, a very important disease and difficult to treat disease. And lots of things are happening as far as triple negative breast cancer is concerned. To chair this session, I'll like to invite Dr. Kunal Jain. He's a close friend, assistant prof of medical oncology in AY DMCH Ludhiana. Dr. Kunal, kindly take over. Dr. Kunal is there? Organizer, Dr. Kunal is there, or should I? Okay, if Dr. Kunal is not there, I'll take over, and we'll proceed to the keynote 522 study. This will be presented by Dr. Priyanshu Chaudhary. He's a consultant medical oncologist at Shalby Hospital, Mohali. And I'll request Dr. Priyanshu to start his presentation.
So good evening, and so thank you for giving me this opportunity. So we'll be discussing today a keynote 522, which is a study of neoadjuvant pembrolizumab plus chemotherapy versus placebo plus chemotherapy, followed by adjuvant pembrolizumab versus placebo for early stage Tnbc. And this subgroup analysis was presented at SABS last year, and it evaluated the event-free survival sensitivity and also subgroup analysis. So a little bit about this trial and pembrolizumab and Tnbc. So pembrolizumab has showed anti-tumor activity and manageable safety in metastatic Tnbc, especially in the first-line setting. And neoadjuvant pembro plus chemotherapy showed manageable safety and anti-tumor activity in early Tnbc in the Keynote 173 and the I-SPY 2 trials. And the Keynote 522 was the first prospective randomized placebo-controlled phase 3 trial of pembrolizumab in early Tnbc in the neoadjuvant and adjuvant settings. The primary analysis showed that neoadjuvant pembrolizumab plus chemotherapy resulted in a statistically significant and clinically meaningful increase in PACR, which was defined as YPT0, T in situ, and YPN0. The neoadjuvant pembrolizumab plus chemotherapy followed by adjuvant pembrolizumab resulted in a statistically significant and clinically meaningful improvement in the event-free survival also. So based on these results, the US FDA has approved pembrolizumab in combination with chemotherapy as neoadjuvant treatment and then continued as a single agent as adjuvant treatment after surgery for the treatment of patients with high risk early stage TNBC. So the study design is like this. The eligibility criteria were age more than 18 years of age, newly diagnosed TNBC, either T1C, N1 to N2 or T2 to T4, N0 to N2, ECOG PS of 0 to 1, and the sample should be available for PDL1 assessment. The patient were randomized in 2:1 ratio to the pembrolizumab arm, which included pembrolizumab every 3 weekly 200 mg, plus the chemotherapy backbone, which consisted of neoadjuvant paclitaxel plus carboplatin in the first 4 cycles, followed by an anthracycline plus cyclophosphamide in cycle 5 to 8. And the doses were standard. Carboplatin was used in 2 schedule, either weekly AUC 1.5 or 3 weekly AUC 5. The comparator, the comparator arm were consisted of the same chemotherapy backbone plus placebo, and post-surgery adjuvant pembrolizumab was given in the same dose for up to 9 cycles. The patient was also stratified according to the nodal status, tumor size, and the carboplatin schedule. So the primary endpoints were PATH-CR assessed by local pathologists in the intention to treat population. The PATH-CR was defined as YPT0, T in situ, and YPN0, and the event-free survival assessed by an investigator in the intention to treatment population. The secondary endpoints were PATH-CR by alternative definition, that is YPT0, YPN0, that is T in situ were not included, or YPT0, T in situ, but node was not evaluated. So other secondary endpoints were overall survival, PATH-CR, EFS, and OS in the PDL1 positive population, and safety in all treated population, on treated patients. The exploratory analysis include EFS sensitivity analysis and EFS in patient subgroup, which we will be discussing today. So this is a summary of the analysis population. Total 1174 patients were randomized between March 17 to September 18. And the pembrolizumab group had around 784 patients. 99.2% was started with chemotherapy, paclitaxel and carboplatin. 92.6% was started with an anthra plus cyclophosphamide. 98% had documented surgery, and 75% had started adjuvant treatment at the time of data analysis. In the placebo arm, 390 patients were allocated. 99.7% started paclitaxel carboplatin. 94.6% started anthracycline plus cyclo. 97.7% had documented surgery, and 85%, around 85% had started adjuvant treatment. The median follow-up was 39.1 months for both the groups. So coming to the baseline characteristics in the intention to treat population, both the arms were well balanced, with just over 50% of the patient having node positivity. Around 3/4 of the patient had stage 2 disease, and a little over 50% patient were premenopausal. HER2 status, around 3/4 of the patient had HER2 negativity by IHC, and a quarter of the patient had 2 positive by IHC, but FISH was negative. Around 80% of the patient had a normal LDH. So the primary EFS analysis showed at a median follow-up of 39.1 months. The 36-month EFS was significantly prolonged in the pembro plus chemo arm, 84.5% versus 76.8% in the placebo arm, with a hazard ratio of 0.63 and a significant p-value of 0.00031. Then coming to the sensitivity analysis, in the primary analysis, patients who did not experience an event at the time of data analysis were censored at the date they were last known to be alive and event-free. While sensitivity analysis included alternative censoring rules, and they also excluded patients who had positive margin at last surgery, and they also included patients with second primary breast cancer and who were started on new anti-cancer therapy for metastatic disease. So in the sensitivity analysis also, we have the results showed that the hazard ratio almost similar, ranging from 0.63 to 0.65, and again favoring the pembro arm with respect to event-free survival. So this also corroborated the primary analysis. In the sensitivity analysis, if we see at 36-month EFS was 85.3% versus 77.9%. Hazard ratio 0.64, again statistically significant. Sensitivity analysis 3, in which positive margin at last surgery was removed from EFS definition. Again, a hazard ratio 0.65, favoring the pembro arm versus the placebo arm. Now coming to the event-free survival subgroup analysis, almost all subgroups showed a benefit in the pembro plus chemo arm versus placebo plus chemo arm. Hazard ratio ranging from 0.60 to 0.58 to 0.73, except for the patient who had stage 3 and the patient who had HER2 positivity 2+ by IHC. But the number of events in this subgroup also is not very high. So coming to the nodal status, it showed pembro plus chemotherapy showed a benefit in EFS in both node negative and node positive subgroup. And the hazard ratio was 0.58 in the node negative arm, favoring pembro plus chemo. In the node positive subgroup, it was 0.65, again favoring pembro plus chemo arm. Now coming to overall disease, stage-wise, if you see, EFS was prolonged in both arms. The hazard ratio 0.60 in the stage 2 disease and the pembro plus chemo arm versus the placebo arm. In the stage 3 disease, the hazard ratio was 0.68, although the confidence interval here is crossing 1. Now coming to the treatment-related adverse effects in the combined phases, that is both the neoadjuvant and the adjuvant phases, almost all patients had some grade of toxicity. Grade 3 to 5 toxicity was present in around 77% patients in the pembro arm versus 73% in placebo arm. The adverse effect leading to deaths were 0.5% in the pembro arm and 0.3% in the placebo arm. And the treatment discontinuation due to toxicities was present in 27% in the pembro arm versus 14% in the placebo arm. The major adverse effects with incidence more than 20% were nausea, alopecia, anemia, neutropenia, fatigue, diarrhea, transaminitis, vomiting, asthenia, rash, constipation, neutropenia, and peripheral neuropathy. Now, if we see only in the adjuvant phase where we had given only the immunotherapy. So in this, any grade toxicity was present in 53.7%, and serious toxicity were only 3.2% in the pembro versus 0.6% in the placebo arm. And there were 2 deaths, one due to pulmonary embolism and one patient from autoimmune encephalitis in the pembro arm, and no death in the placebo arm. Again, the main toxicities were arthralgia, rash, pruritus, asthenia, diarrhea, fatigue, transaminitis, etc. And now coming to the immune-mediated adverse effects and infusion reaction in both in the combined phases. Here around almost 43% patient had any grade toxicity, but serious toxicities were 10.6%. And again, 0.3% death rate in the pembro arm and around 11% discontinuation rate. The most common toxicity was infusion reactions followed by hypothyroidism, skin reaction, and adrenal insufficiency, pneumonitis, thyroiditis, hypophysitis, which are common expected side effects from immunotherapy. If we see only the adjuvant phase here, the most common toxicities were hypothyroidism, infusion reaction, skin reactions, pneumonitis, adrenal insufficiency, colitis, and myocarditis. Again, serious adverse effects were present in 2%, and 0.2% patient had death due to immune-mediated adverse effects. So to summarize, in the phase 3 Keynote 522 study, neoadjuvant pembro plus chemotherapy followed by adjuvant pembro resulted in a statistically significant and clinically meaningful improvement in the event-free survival. The pre-specified event-free survival sensitivity analysis showed a robust treatment benefit of neoadjuvant pembro plus chemotherapy, followed by adjuvant pembrolizumab for previously untreated non-metastatic TNBC. This benefit was generally consistent across a broad selection of pre-specified patient subgroups, including those defined by nodal status and overall disease stage. The safety profile was consistent with the known profile of each regimen, with no new safety concerns. And these results further support pembrolizumab plus platinum-containing neoadjuvant chemotherapy, followed by adjuvant pembrolizumab after surgery as a new standard of care treatment regimen for patients with high risk, early stage TNBC.
Thank you, Dr. Priyanshu. I mean, that was a lovely presentation, absolutely clear presentation you had. You would like to give in any stage, particularly stage 2 or stage 3 or to all patients?
Sir, I'll prefer definitely in probably in an N2 disease, N1 to N2, and if it's better if we have, although this trial showed that the benefit was present in both, PD-L1 positive and negative, but I think there were only 10% patient who had the PD-L1 negativity, and that subgroup was pretty less. So I'll definitely try to select patient who were PD-L1 positive. I have used in only one patient clinically T2N2, TNBC, young female BRCA positive. Although PD-L1 was 0, but still she had a PAT CR. But we don't know whether this is due to doublet platinum combination or pembrolizumab. But still, she's having she had a PAT CR and she's disease free now post surgery.
So my second question is, since you have brought it out, will you do PDL testing before starting this?
Although the recommendation is without PDL1, but I do like to do a PDL1, and if it is positive, then I counsel a little bit more to the patient, cost being a factor. And the patient I had used, I only used it in the neoadjuvant setting because of cost constraint.
Okay, thank you very much for the lovely presentation. And now we proceed to the next presentation. Redefining the management of HER2 negative early breast cancer in the era of precision medicine. This talk will be delivered by Dr. Chitresh Agarwal, our friend in the sister hospital in Panchkula. He's a consultant medical oncologist, Alchemist Hospital. Dr. Chitresh, please.
Good evening, sir. Is my slide visible?
Yes.
Okay.
You are audible and visible.
So good evening, all of you. I thank you, sir, for providing me this opportunity. And the topic assigned is redefining the management of HER2 negative early breast cancer in the era of precision medicine. So the agenda for this, we will see the background and some of the trials which are done in this setting, and then we will like to see the conclusion out of this all. Now, most patients are diagnosed with early stage breast cancer. Patients diagnosed with early stage breast cancer, they have a high survival rate compared to those who have advanced disease. Now, if we see the survival rates, they differ drastically between early and advanced disease. And if we see these, we will be able to see that the survival varies from 98.5% to 95% or more than 95% in early disease. And it goes to as dismally low as around 20 to 25% in advanced disease cases. Now, the treatment options for HER2 negative early breast cancer, we are all aware of this. We see whether the patient is hormone receptor positive or hormone receptor negative. Then we see whether the patient is HER2 positive or HER2 negative, or a patient is triple negative. And then depending on the tumor characteristics, we decide whether a patient is to be given neoadjuvant or not. And then depending on the response, we send these patients for surgery, followed by adjuvant chemotherapy, radiotherapy if indicated, or adjuvant endocrine therapy if indicated. Now, BRCA mutation prevalence in unselected breast cancer is approximately 5%. Individual studies in unselected BRCA breast cancer populations report varying frequencies of BRCA mutation. Only a few studies have actively looked at BRCA mutation rates. Variability may be due to the method of analysis and whether populations have founded mutations or not. Now, this is a chart which shows the prevalence of BRCA1 and 2 mutations in unselected breast cancer populations. So in European Union, it is anywhere close to 2%, and in Sweden, it can be as high as around 10 to 11%. So if we take the average, we will see that around 5% of breast cancer patients will actually will have a BRCA mutation. Coming to the BRCA mutations in Indian patients, there are some studies and some evidence, and we see the prevalence of pathogenic mutations in breast cancer patients is higher in Indian patients when we compared with other populations. And data are available to suggest that 50 to 80% individuals at risk of having a hereditary breast cancer are actually never tested, as they do not meet the current criteria for testing. So patients with BRCA mutation early breast cancer have distinct tumor characteristics compared to the sporadic population. BRCA mutant breast cancer is characterized by a more aggressive phenotype than the sporadic disease. So we all know this, but it is better to revise that patients are diagnosed at much younger age. These are of higher grade, more CNS metastasis, more contralateral ipsilateral disease, and patients with BRCA mutant breast cancer may have a higher risk of recurrence. So in the early breast cancer setting, upfront knowledge of BRCA status may inform decisions around surgery and targeted treatments. Early breast cancer, this is important. Why? Because we can see whether a patient requires only treatment to the affected side, or we have to take some decisions on the prophylactic side. And also now, as we will discuss in the subsequent slides, whether there is any role of PARP inhibitors, immunotherapies, capecitabine, or some agents which are not earlier, which were not earlier available, but now there is growing evidence to the role of all this. So coming to the NCCN criteria for BRCA testing for hereditary risk in individuals diagnosed with breast cancer, the NCCN criteria fits that individuals who are diagnosed with breast cancer, if a lady is less than 45 years of age, we should definitely test it. If it is less than 50 years, we have to see additional breast cancer primary and family history criteria. And if any of these criteria are met, we can go ahead with testing. If any lady who is more than 51 years of age, either she should have a family history or a personal history criteria, or any age of individual diagnosed with breast cancer, who has any age who has triple negative breast cancer, personal history, family history, male breast cancer, or ethnicity, which is most commonly the Ashkenazi Jewish, BRCA testing is recommended. So coming to the first evidence in this setting of early breast cancer, we have Olympia, which is the latest trial, phase 3 study of olaparib versus placebo as adjuvant treatment for high-risk germline BRCA mutated HER2 negative breast cancer. So the eligibility for this trial was germline pathogenic or likely pathogenic BRCA1 or BRCA2 mutation, stage 2 or stage 3 breast cancer, HER2 negative. The patients could be hormone receptor positive or triple negative, and the patients have completed local treatment and more than 6 cycles of either neoadjuvant or adjuvant chemotherapy. And these chemotherapy should contain anthracyclines and or taxanes. Now, if the setting was neoadjuvant, then if the subgroup was triple negative breast cancer, those patients who received neoadjuvant and triple negative and they did not achieve PCR, that is non-PCR candidates, they were given randomization, or for hormone receptor positive patients who had no PCR and CPS plus EG score was more than equal to 3. In the next slide, I will tell you what is CPS plus EG score. And in adjuvant group, it is triple negative breast cancer if the tumor is more than 2 centimeters or node positive disease, or if the tumor is, if the disease is hormone receptor positive, then more than equal to 4 positive lymph nodes. So for these two groups, randomization was done for olaparib 300 milligram twice daily or to placebo, and the primary endpoint was IDFS, that is invasive disease-free survival, and the duration of the treatment was 1 year. Now, what is the high-risk criteria definition for Olympia trial? As I have previously mentioned, for triple negative breast cancer patients, the definition is that if the patient was treated with adjuvant chemotherapy, then we required to have axillary node positive disease or an invasive primary tumor measuring at least 2 centimeters on the pathological analysis, and the treated with neoadjuvant chemotherapy, they were required to have residual invasive breast cancer, that is, there is no achievement of PCR. And for hormone receptor positive breast cancer, it is if treated with adjuvant chemotherapy, they were required to have at least 4 pathologically confirmed positive lymph nodes. And if they're treated with neoadjuvant chemotherapy, they were required to have no PCR plus a CPS EG score of 3 or higher. Now, what is this CPS plus EG score? CPS plus EG score provides a more refined prognostic categorization of patients with breast cancer after neoadjuvant chemotherapy versus the clinical or pathological stages alone. So C is the clinical stage, plus P stands for pathological stage, and E stands for estrogen receptor status, and G stands for grade. So based on this, so clinico-pathological staging plus the estrogen receptor status and the grading of the tumor, we would score these patients from 0 to 6. And if the patients had this score of more than 3, then they were eligible for this. So coming to the trial results, olaparib reduced the risk of invasive recurrence or death by 42% versus placebo. So if we see the invasive disease-free survival, that was the primary endpoint, we will see that the 3-year IDFS rate in olaparib arm was 85.9%, and in placebo arm, it was 77.1%, and the hazard ratio was 0.58, with the absolute difference being 8.8%. A consistent benefit was seen across all the IDFS subgroups, whether prior chemo was given or not, prior platinum agents were used or not, hormone receptor status or the Graca status. All these subgroups, they favored the use of olaparib. Now, 87.5% of the patients who were treated with adjuvant olaparib were free of distant recurrence or death at 3 years. And that is the secondary endpoint, that is the DDFS, that is distant disease-free survival. And here also the DDFS rate at 3 years of olaparib was 87.5% compared to placebo, which had 80.4%, and the absolute difference here also being around 7.1%. Now, fewer deaths were reported in the olaparib group compared with placebo. So when we see the secondary endpoint of overall survival, we will see that the 3-year overall survival rate of olaparib was 92%, and compared to the placebo arm, with that 88.3%, and the absolute difference being close to 4%. Now, adverse events were mostly mild and moderate in the olaparib arm. There were certain adverse events which were very common, as we commonly know with the use of olaparib: nausea, fatigue, anemia, diarrhea. These are the very, very common side effects that we encounter with the common use of olaparib. But anemia was only grade 3 adverse events which were occurring more than 5% of the patients in this trial. There was no clinically meaningful change in the fatigue severity across the duration of the study. Fatigue was a primary PRO endpoint, and the pre-specified clinically meaningful difference of 3 points was not met. Patients treated with olaparib, they experienced slightly more fatigue than patients who were treated with the placebo. Difference was significant but not clinically meaningful. So the clinically meaningful differences in nausea and vomiting with olaparib versus placebo were small, and they were resolved after treatment cessation. So now moving from the Olympia trial to the addition of PARP inhibitors, that is veliparib plus carbo or carboplatin alone to standard neoadjuvant chemotherapy in triple negative breast cancer. Here we are talking of the Brightness trial. Now it's a busy slide. I will just enumerate the three arms. Again, the same inclusion criteria of women more than 18 years, histologically or cytologically confirmed invasive stage 2 or stage 3 triple negative breast cancer patients, and candidates for potentially curative surgery with documented germline BRCA status. These patients were randomized to either paclitaxel alone or paclitaxel plus carboplatin or paclitacarbo plus veliparib. And the segment 2 of this was doxorubicin, cyclophosphamide, then surgery, and the endpoint was PCR, and the secondary endpoints were EFS, OS, and safety. Now, what we see in this slide is that adding carboplatin to paclitaxel followed by doxorubicin and cyclophosphamide, they improved the PCR rate significantly and translated into an improved event-free survival after a median follow-up of 4.5 years. But addition of veliparib did not impact the pathological complete response, event-free survival, or OS. So what this trial tells us is that in addition to the paclitaxel, if we add carboplatin, there is definitely an achievement of higher PCR, which is translating into improved EFS, but further addition of veliparib did not show much improvement. Now, the NCCN and the ESMO guidelines both recommend capecitabine as an adjuvant treatment for patients with Tnbc and residual disease following neoadjuvant chemotherapy. This is the CREATEX trial that we all are aware of. Now, guidelines here do not currently recommend capecitabine use in hormone receptor positive, HER2 negative breast cancer patients who have residual disease for the use of capecitabine. And if you see the hazard ratios also, we will see that the maximum benefit is in those populations who are triple negative subgroup. Now, the CIS-UCC001 randomized clinical trial, it asked a very basic question that does therapy with low dose capecitabine maintenance after standard adjuvant chemotherapy reduces the risk of relapse and death among patients with early stage TNBC? And the conclusion was that this randomized clinical trial found that in women with early stage TNBC, maintenance therapy with low dose capecitabine, it significantly improved the DFS at the end of 5 years. With capecitabine here, the 5-year DFS was 82.8% versus observation alone, which was 73%, and the hazard ratio for the risk of recurrence or death was 0.64. So moving on to the other available evidence of randomized trial of adjuvant chemotherapy regimen versus capecitabine in older women with early breast cancer. This is the 10-year update of the CALGB 49907 trial. Here, ladies who were more than 65 years of age, early breast cancer, performance status of 0 to 2, adequate hematological, renal and hepatic functions and clear surgical margins. They were given either standard chemotherapies with CMF or AC or capecitabine. See the doses of capecitabine used 2000 milligrams per meter square per day for 14 consecutive days, every 3 weeks for 6 cycles. And the primary endpoint was RFS, that is recurrence-free survival, and the trial was non-inferiority of capecitabine. And here we see the 10-year trial updates, and this show that with the CMF, the hazard ratio was 0.8, and with the survival probability was 0.84 in hazard ratio with capecitabine and CMF. Now coming to the Keynote 522 is a phase 3 trial of pembrolizumab plus chemotherapy as neoadjuvant therapy and pembrolizumab monotherapy as adjuvant therapy in early stage TNBC. So newly diagnosed TNBC, T1C node positive or T2, T4 node 0 to 2, ECOG performance status 0 to 1, they were randomized to neoadjuvant cycles of pembrolizumab plus carboplatin plus paclitaxel or paclicarbo alone, then pembro plus doxorubicin plus cyclophosphamide or AC alone, then surgery followed by adjuvant 9 cycles of pembrolizumab or placebo. And the primary endpoints of this trial was locally assessed PCR in intention to treat population and investigator assessed EFS in intention to treat population. Now, if we see the paired analysis of Keynote 522, the primary endpoint was pembro plus chemo versus placebo plus chemo, and here the achievement of PCR was higher with pembro plus chemo, 64.8% versus 51.2%, and there was an absolute difference of around 14% with addition of pembrolizumab in achievement of the primary endpoint, that is PCR. And if we see the first EFS analysis, we will see that the number of events were less, and this translated into 91.3% versus 85.3% at the end of the 15-month median follow-up, and there was some betterment with the use of pembro plus chemo and pembro maintenance. Now, updated findings demonstrated robust treatment benefit with experimental regime in an EFS sensitivity analysis, and the benefit was observed irrespective of the nodal status, overall disease stage, menopausal status, HER2 status, and LDH. So if we see this analysis, we would see that almost all the subgroups, they have a benefit of usage of pembrolizumab plus chemo followed by adjuvant pembrolizumab. Now moving on to the Impassion 031, which is a phase 3 trial investigating adesolizumab plus chemotherapy as neoadjuvant therapy in early stage TNBC. Here in this trial, TNBC with primary tumors which were more than 2 centimeters, clinically T2 to T4, node negative to node 3, and non-metastatic diseases, they were randomized to adesolizumab plus nab-paclitaxel, followed by adesolizumab plus AC, then surgery, followed by adjuvant adesolizumab for 11 cycles, or only single-agent chemotherapy plus AC, followed by surgery and then observation. Here also the primary endpoint was PCR. Now, if we see the pathological complete responses in Impassion 031, in this trial, adesolizumab plus neoadjuvant chemotherapy, this significantly improved the PCR rates, and these rates were regardless of the PD-L1 status. If we see this for the overall population, the PCR rates, they were around nearing 60% versus 40%, and the absolute difference was 16.5%. In populations which were PD-L1 positive, this benefit was even more drastic with 68.8% of the PCR achieved versus around 50%, and the absolute difference being 20%. Now, the median overall survival was not reached in any treatment arm in the Keynote 522 or Passion 031. So we don't have this data as of now. Now, what are the immune-mediated adverse events which occurred in both of these trials with the use of either pembrolizumab or adesolizumab? And we see that all the most common reactions in Keynote 522, they were infusion reactions, hypothyroidism, severe skin reactions, and adrenal insufficiency. And here in Passion 031, it was rash followed by infusion-related reactions, which were the two most commonly seen side effects. Now, some of the immune-mediated adverse events observed in Keynote 522 and Passion 31 may be severe, irreversible, and or require lifelong medications in patients with a potentially curable breast cancer. So hypothyroidism, hyperthyroidism, and adrenal insufficiency, they may require treatment and or hospitalization, and this may be lifelong and can be life-threatening. Diabetes, it tends to be irreversible, requires lifelong hormone replacements, and can lead to hospitalization and mortality if undetected. Hepatitis may require hospitalization and can lead to rapid liver failure, and Guillain-Barré syndrome can cause paralysis, leaving the patient unable to breathe independently. So deaths due to immune-mediated adverse events occurred in Keynote 522. In the pembrolizumab plus neoadjuvant chemotherapy arm, there were no deaths reported in to adverse events in Passion 031, but in Keynote 522, the total were 5 in comparison to 1 there and 2 in adjuvant phase versus none in the placebo arm. Approximately 1 in every 4 patients in the IO arms of both trials discontinued treatments early due to the occurrence of these adverse events. In both arms, the rate. Pardon?
1 minute. 1 minute, I said. Carry on, carry on.
In both arms, the rates of discontinuations due to adverse events were higher in Keynote 522 and Passion 031 versus trials of Pembro and Adesolizumab in the metastatic setting. And patients with early breast cancer may be less tolerant of adverse events than those with the metastatic breast cancer. Now, moving on to the use of CDK4/6 inhibitors in the early positive breast cancer hormone receptor. So, Monarchy investigates adjuvant endocrine therapy plus minus abemaciclib in patients with high risk, node positive, hormone receptor positive, HER2 negative early breast cancer. So patients with or without prior adjuvant chemotherapy, more than 4 positive lymph nodes or 1 to 3 axillary lymph nodes with at least one of the following: either tumor size more than 5 centimeter or a grade 3 or centrally tested Ka67 of more than 20%, up to 12 weeks of endocrine therapy or completing last non-endocrine therapy, and less than equal to 4 months since definitive surgery. Cohort 1 based on clinical pathological risk factors, that is more than 4 lymph nodes or 1 to 3 lymph nodes with a higher grade or tumor size more than 5 centimeters. Or cohort 2 based on Ka67 and 1 to 3 lymph nodes centrally tested Ka67 of more than equal to 20%, not grade 3 tumors and tumor size not more than equal to 5 centimeters. They were randomized to either abemaciclib 150 milligram BID up to 2 years plus the standard of care endocrine therapy or standard of care endocrine therapy alone, and the primary endpoint of this trial was IDFS. Now, Monarchy adjuvant abemaciclib plus ET in high-risk node-positive patients, abemaciclib plus endocrine therapy demonstrated a statistically significant improvement in IDFS versus endocrine therapy alone. If we see the 2-year IDFS, it was 92.3% with abema plus endocrine therapy and only 89.3% in endocrine therapy alone. And if we see the distance relapse-free survival, here also 3-year rates of DRFS was 93.8% in abemaciclib plus endocrine therapy arm and only 90.8% in endocrine therapy arm. And the common sites of distant recurrences were bone, liver, and lung.
Kindly conclude, please.
Yes, sir. So IDFS benefit was maintained with additional follow-up, and the 30.4 reduction in the risk of IDFS event, the absolute difference in IDFS rates were 5.4% at the end of 3 years. So this all adverse events, they were adverse events of any grade more than 20%. They were not much in the use of abemaciclib. Now I will just mention that apart from abemaciclib, other agents used were palbociclib in Penelope B and PALAS trial. And both of these, the palbociclib trials have turned out to be negative. So this is about the negative trials. So to conclude, Recent developments in our understanding of breast cancer molecular biology and heterogeneity have led to substantial improvements in outcomes. The value of identifying a high penetrance mutation in breast cancer gene is well established, and identifying for germline BRCA1-2 mutations has now moved beyond prevention to treatment of both early and metastatic breast cancer. Olympia trial reported the clinical benefits of a PARP inhibitor as an adjuvant treatment in germline BRCA mutation, HER2 negative early breast cancer. Seminal trials with immune checkpoint inhibitors like Pembro and Atezo, and in combination with CDK4/6 inhibitors like Abima and Palbo, provide additional data on the evolution of treatment strategies in early breast cancer. And understanding the role of these agents in the light of existing therapies allows us to optimize the treatment strategies in a way that we achieve the best possible outcomes for these patients. Thank you.
Thank you, Dr. Chitresh. That was an exhaustive lecture on basically treatment of all types of early breast cancer except for HER2 positive. Fantastic presentation. My only question is, tomorrow triple negative patient comes to you, how will you plan her treatment?
So, sir, I have yet not used either the testing or the use of olaparib. And so the data is compelling, and I will start using the checking of germline BRCA for all these patients. And if the patient is affording, then I will definitely counsel for the use of olaparib. But till now, I have not done so.
So what about the keynote 522 trial? Will you incorporate in the patients?
Practically speaking, due to the higher incidence of higher adverse events in this setting and the cost of the therapies involved, I don't think many of the patients would actually end up taking any of these therapies that we are discussing.
Okay. Dr. Priyanshu, have you got any experience at it? Can both these drugs can be used? Obviously, in adjuvant, after adjuvant treatment, when you start, if patient is also BRCA positive, will you use pembrolizumab immunotherapy as well as olaparib? Acha, he is not. Dr. Chitresh, should you like to answer that? Any data is there? Okay, so these are the questions which we would like to know, and we do not know the answers of these questions. And as we proceed, these questions will be, this answer will be there. Now, going on to the next session, that is a fixed dose combination of capecitabine and cyclophosphamide in metastatic breast cancer. This lecture will be given by Dr. Sandeep Kukar. He's our close friend, senior consultant medical oncologist at Sohana Multi-Specialty Hospital. Dr. Sandeep, please.
Good evening, sir. Good evening, everybody.
Good evening.
So my PPT is visible?
Yes, yes. PowerPoint, kindly make it PowerPoint.
So I think it is okay now.
Yeah.
So good evening, everyone. Moving on to the next talk on a fixed dose combination of capecitabine and cyclophosphamide. The scope of the presentation would include the journey of oral fixed drug combination, capecitabine and cyclophosphamide, COMCAPC, rationale of the combination, what is the concept of metronomic chemotherapy, existing data and challenges, the pilot clinical phase 2, phase 3 study and its results, advantages of the combination, and the concluding remarks. So MBC is a difficult condition to treat, and the patients usually, we consider them for palliation or a prolonged symptom-free survival. Anthracyclines and taxanes are effective agents in advanced breast cancer and prolonged survival time. So they are considered as most effective cytotoxic agents, but majority of the patients, they will fail to respond to first-line treatment. And so MBC will present a significant challenge to oncologists as a community. So how the journey has evolved from capecitabine as a single agent to the use of capecitabine and cyclophosphamide. The usage and the journey started a decade back, approximately in 2007, when the first full dose combination was used. Later on, as we gained more and more experience, we moved on to the SWOG trial in 2012, then the Penelope project 2018, and finally in 2021, the DGCI led to the approval of Comcapsi for the use in MBC patients. So before going on to the presentation, what are the patient's perception? Very important, because oral therapy is always a preferred choice for these patients. And the next question is, does it work? Yes, definitely. So we will have the answer in the coming slides, and whether it will be covered in insurance or not. So why capecitabine is a preferred partner? It has got a high single agent activity. It has got a unique safety profile with no alopecia and low incidence of myelosuppression with its own unique toxicities. The available drugs like Paclitaxel, Dosi, cyclophosphamide, they upregulate the thymidylate phosphorylase activation and lead to the enhanced conversion of capecitabine to its active form of 5-FU. So this is a rationale of combination where capecitabine, it gets converted from, it goes from intestine to liver, and then from liver to the tumor tissues. So the important point is this thymidine phosphorylase, where cyclophosphamide, besides its own anti-cancer activities, it has got synergistic action with the upregulation of thymidine phosphorylase, leading to the enhanced concentration of 5-FU in the tumor tissues and an enhanced cytotoxic effect. So when do we combine? Whenever we use the combination of these drugs, there are multiple actions that can be seen apart from the direct cytotoxic effects on the cancer cells. It can be the angiogenic effects, it can be the immune-mediated effects, it can be the endocrine effects. So these all are dependent on the class of the drugs, the plasma concentration of the drugs, and the schedule, whether it is intermittent or continuous. So these all are the factors which have to be taken into account before proceeding, before choosing a combination of a metronomic chemotherapy. So this was the first data of a phase 2 trial where capecitabine along with cyclophosphamide, it was used in patients with MBC, the SWOG 0430 trial, where cyclophosphamide was used as 100 mg per day and capecitabine was 1500 BD dosing. So key learnings were PFS and OS and the response rate outcomes with capecitabine and cyclophosphamide, they compare favorably with single agent capecitabine. PFS and OS and overall and response rates, with capecitabine and cyclophosphamide, they were favored with the combination of those with bevacizumab, sorafenib, and hexabiplone. They are less expensive and more convenient to administer. They can be used in patients with less than 65 or more than 65 years of age. And flat dosing of oral agents, it can be used. Earlier, the concept was a BSA-based dosing of the agents. But here, we noted that flat dosing of the oral agents, it can be used, indicating that clearance of both the drugs is independent of BSAs. So yes, the SWOG was an all oral regimen, which would be of interest, and more experience and more trial-based evidence was needed before we could conclude that a fixed drug combination was really very, very effective. So this was a Penelope project where a pan-European meeting with on the use of metronomic chemotherapy in advanced breast cancer. So again, the similar points. So what were the key learnings from the project? That metronomic chemotherapy is the use of a frequent, regular, without any intervals, low doses, but pharmacologically very, very active concentrations of the drugs in plasma without toxicities. So mechanism of action, apart from cytotoxic effects, could be the inhibition of angiogenesis or the immune-mediated effects. Of all the drug combination, capecitabine, along with cyclophosphamide and vinorelbine, they show additional mechanism of action, but still we do not have any phase 3 data on the combination of these drugs. Very good toxicity profile is lost if they are combined with other non-metronomic drugs. So the other studies which have led to the insight on the use of metronomic chemotherapy, this was a Japanese study which was conducted, where again capecitabine in a low dose along with cyclophosphamide were used. This was a Chinese study where again, cyclophosphamide along with capecitabine in low doses was used. So studies have definitely led to our insight and our knowledge about the use of capecitabine and cyclophosphamide because they have a very good efficacy and a promising tolerability and activity. The low dose FDG, it potentially provides an attractive all oral alternative, lesser pill burden, giving patients more and more freedom and a sense of control on their treatment. Also, potentially provide balance in the terms of efficacy as well as safety. So on the basis of metronomic chemotherapy, it has been used in head and neck cancers as well. And I think there are many studies from Tata where Dr. Banavali and Dr. Sudeep Gupta have been on the forefront with the use of metronomic chemotherapy in head and neck as well as in breast cancers. So there are no, what are the challenges regarding the use of FDC combination? There are no randomized phase 3 data. There is no pharmacokinetic data. There is no confirmation of synergism on the use of cyclophosphamide and capecitabine. The doses earlier the trials have used, they were non-metronomic, they were therapeutic doses. No systemic drug development intent till the formulation of this FDC combination. So this was a phase 2, phase 3 data which was conducted in February 2015 to November 2018 in approximately 15 centers pan India, where this FDG was fixed drug combination was used in MBC patients with the failure of anthracycline and taxane-based chemotherapy. So there are two different formulations. One is 700 plus 30 milligram and other is 400 plus 30. So patients were divided into 3 different subgroups. So DGCI gave the permission and there were 3 different dose levels and 3 different parts of this trial. So the key inclusion criteria were more than females more than 18 and less than 65 years, histopathologically confirmed breast cancer, MBC with the pre-treated or failure of anthracycline and taxane-based regimen, at least one measurable lesion as per the RECIST criteria, previous chemotherapy, radiotherapy completed 4 weeks before the start of this drug. Exclusion criteria, majority of the patients where the CNS metastasis was there, they were excluded. Patients who have taken more than one MBC chemotherapy regimen for MBC, they were excluded. For ER positive patients, it was at the discretion of physician to use endocrine therapy, and pre-existing motor and sensory neuropathy was one of the exclusion criteria. Primary efficacy was best overall response rate with CR and PR. Secondary efficacy was disease control rate, CR, PR, and stable disease. And other secondary endpoints were any adverse effects that were reported during the study period. So this was the patient disposition where overall D1, D2, D3, 3 subgroups were there. But D1 was not included in the analysis because it did not meet the pre-specified criteria of more than 3 responders out of the 22 patients. So this D1 was excluded and D2 and D3, they were taken into account for the analysis of the patients. So demographic profile, majority of the patients were in the 5th decade, around median age was around 49, 50 years, which conforms with the breast cancer patients who are pretty young and in particularly in the triple negative subset. BSA again, it conforms with the Indian setting of around 1.5, whereas in the Western population, it goes beyond 1.8 to 2. So results as per the ITT population, we can see here that in D2, the best overall response rate was in the range of 29 to 30%. D2 the subgroup was doing better compared to the D3, where differences might have been there because of the increased dosage, where 2200 plus 100 was used. Disease control rate again in the range of 87% compared to the 84% in the D3 subgroup. So in the per patient protocol population, where few of the patients were excluded depending on the violation of the protocol. So again, similar results were observed. In the best overall response rate was in the range of 31% in D2 subgroup and 25% in the D3 subgroup, whereas the disease control rate, CR, PR, and stable disease was in the range of 89% versus 87%, which is very, very compelling. So no other safety concerns were seen. Whatever we have learned apart from our previous knowledge, that there is some sort of diarrhea and hand-foot syndrome. Similar percentages of diarrhea and hand-foot syndrome were observed. Only some form of less than 5% of the patients, they had a hematological toxicity in the form of anemia, leukopenia, and neutropenia. Whereas in dose level 3, the hematological toxicities were pretty much increased compared to the dose level 2. So comparison with the previous studies, we can see here that the disease control rate is almost in the range of 87. The Indian study demonstrated the disease control rate of around 87 to 89%, which is maybe a bit higher than what the international studies have reported. And the less incidence of neutropenia and hand-foot syndrome was noted in the Indian study. So again, the safety analysis as far as the other lab parameters are concerned, apart from neutropenia and HFS, no other safety concerns were noted, and the proportion of neutropenia and hand-foot syndrome was quite less compared to the other international studies. So this was way back in 1999, where there was a demonstration of upregulation of the thymidylate phosphorylase activity with the use of cyclophosphamide, and enhanced concentration of the enzyme was noted when this cyclophosphamide was used along with capecitabine. So what are the challenges to FDC? Incompatibility between the two molecules, where cyclophosphamide and capecitabine, they can be impregnated together. Chances of impurity generation, particle size, and the differential release of the drug. So challenges were circumvented by the research team by Intas, where patent has been awarded for particle size, and patent was in progress for tablet-in-tablet form of treatment. So this is where cyclophosphamide tablet is incorporated or impregnated into the capecitabine layer, which is a unique formulation model of this fixed drug combination. So it can be 1 + 1 is equal to 2, or in fact more than 2. It can be 2, 2 or 5. So I think the trial has met its endpoints with the approval given by DGCI. So there are two different sizes, 400 + 20 and 700 + 30. So the D2 and D3, the dosage, whatever we have seen. So accordingly, it is very, very easy to titrate whether 2 tablets can be given in the morning and 1 tablet in the evening. And in the D3, 2 tablets in the morning and 2 tablets in the evening can be offered. So this is the DGCI approval that has been awarded to Comcapsi for the use of this unique formulation in MBC patients. Final concluding remarks. It has got synergistic anti-tumor activity because cyclophosphamide enhances the concentration of capecitabine, and established efficacy has been seen in the phase 2, phase 3 clinical trial in India. Based on the clinical trials and the detailed review with the other studies, it can be stated that this fixed drug combination can be really, really helpful for those patients who demand who are a suitable candidate for an oral form of therapy. So only FDC that has proven the flat dosing concept. So convenience of taking few tablets instead of many, because 2 tablets have been incorporated, or cyclophosphamide has been impregnated into capecitabine. So there are certain challenges in the treatment as well. The patients who present to us, they have multiple failed lines of treatment, so it can be an effective alternative to those patients. Whether they can be a suitable alternative to hormone receptor positive or only a triple negative HER2, that is one question that needs to be answered. For patients, those who have a poor venous access, this is a very, very good alternative. Patients who have not been keen for IV treatment. Patients who cannot afford the novel forms of therapy, this is a cheaper alternative. It has got a manageable toxicity profile, where I think hand-foot syndrome and diarrhea, these are the only 2 limiting points. Beyond MBC, although they have not been labeled and have not been approved by DGCI, but people have used in different indications. One important point to state that dose level 1, which was a suboptimal level, and it did not meet the pre-specified subset criteria of achieving an optimal response, so should not be used. Either in dose 2 or dose 3 should be used. Ideal should be dose 2 in combination with other drugs. So I think this is a fixed drug combination. Also, it should not be tried with other agents, other chemotherapy agents. So it takes, there are some interesting facts regarding the development of.
Kindly conclude.
Yes, this is the last slide, sir. Out of 15,000 substances, one drug is usually, we get the one drugs, and people spend billions of drugs for having developing of one drug. It takes years and years from bench to bedside to develop one drug. So, so my concluding remark is this is an effective alternative for many of the MBC patients who cannot afford expensive therapies and are and have been heavily pre-treated with chemotherapy. So I think this is a very good combination. Thank you.
Thank you, Dr. Sandeep. Lovely presentation. I think this is a first data which has come from India and Indian patients. And you see, I give due regards to Dr. Banavli, who spent his lifetime searching for metronomic schedules for our patients who are poor. And I can assure you that many sort of patient come, whether any positive, negative, who can't afford any other treatment apart from this. And this has been I've been using it quite commonly in my practice. So Dr. Sandeep, you must be using quite common, or it is rare? I think he's not there. So basically I use it and I found it very effective. Now,
Sir, I have used in few of the patients and with a very good response rates, particularly in the metronomic settings. And I think this is a very, very good alternative, and majority of the patients, wherever we have used, I think majority of the patients, they derive a substantial amount of response as well and without toxicity.
Okay, thank you very much. We proceed to the next topic, that is cyclophosphamide-free adjuvant chemotherapy for ovarian protection in young women with breast cancer. Now, this lecture will be given by Dr. Mukesh Bansal. He's a young colleague from, he's a consultant medical oncologist from IV Hospital, Mohali. So, Dr. Mukesh Bansal, kindly proceed with your topic. Can you unshare, Dr. Sandeep? Okay. You see, cyclophosphamide, you see, interfere with pregnancy, and we get many instances when patient want pregnancy and they ask us questions. So this is one, probably we'll see what answer Dr. Mukesh gives.
Good evening, sir, and good evening, everyone. Thank you for giving me this opportunity, sir. Are my slides visible, sir?
Yes, yes, yes.
Okay. So the topic given to me is cyclophosphamide-free adjuvant chemotherapy for ovarian protection in young women with breast cancer. So it is a randomized phase 3 trial done in China between 2011 to 2016, the results of which were published last year in 21. So this study is basically trying to, as the breast cancer is getting detected in younger and younger patients, so trying to preserving the fertility is very important. So this is a concept that if we omit the cyclophosphamide from the regime and substitute it with paclitaxel, can we preserve the fertility and can we have the better menstrual resumption chances? So the chemotherapy-induced premature menopause leads to some consequences, the most important of which is infertility in young patients. So this is a randomized phase 3 trial to determine whether a cyclophosphamide-free adjuvant chemotherapy regime would increase the likelihood of menses resumption and improve survival outcomes. So the methods were the young woman with operable ER positive, HER2 negative breast cancer after definitive surgery were randomly assigned to receive adjuvant epirubicin and cyclophosphamide, followed by weekly paclitaxel in one arm, and epirubicin and paclitaxel, followed by weekly paclitaxel in the other arm. So the patients taken were only hormone positive and HER2 negative. Both nodal positive and nodal negative patients were eligible. The nodal regional node positive patients were have to be pathologically confirmed, and nodal negative patients were taken as such because at that time I think there were no concept of oncotype DX stratification. So almost all the patients who were high risk by that the tumor disease size criteria or histological grade criteria, basically tumor diameter of more than 1 centimeter with histological grade 3 or tumor diameter of more than 2 centimeter with histological grade 2 were taken. So all the patients received at least 5-year adjuvant endocrine therapy after chemotherapy. So the two co-primary endpoints were the rate of menstrual resumption at 12 months after chemotherapy and 5-year disease-free survival in the intention to treat population. So the results of the study were, it was done between January 11 and December 16. There were total 521 patients of 18 to 40-year age group. The median age was 34 years. 261 patients were in the epirubicin cyclophosphamide followed by weekly pacli group, and 260 were in the epirubicin paclitaxel followed by weekly pacli group. So the rate of menstrual resumption at 12 months after chemotherapy was 48.3% in the cyclophosphamide group and 63.1% in the paclitaxel group, with an absolute difference of more than 14.8%, which was found to be statistically significant. So the post-hoc exploratory analysis by patient-reported outcome questionnaires indicated that pregnancy might occur in fewer women in the cyclophosphamide group than in the paclitaxel group. So, and at a median follow-up of 62 months, the 5-year disease-free survival was 78.3% in the cyclophosphamide group and 84.7% in the paclitaxel group, which was not statistically significant. The safety data was consistent with the known safety profiles of relevant drugs. So these are the survival outcomes. In the first chart, we can see disease-free survival, which was 84% in the paclitaxel group and 78% in the cyclophosphamide group, which was better in the paclitaxel group but was not found to be statistically significant. The distant disease-free survival was also not statistically significant, and the overall survival between the two groups was also comparable. It was not found to be statistically significant. So the conclusion of this study is that we can safely substitute cyclophosphamide with paclitaxel in the adjuvant hormone positive HER2 negative young patients with the intention to preserve the fertility with better chances of menstrual resumption and no statistical significance in disease-free survival or overall survival. So the cyclophosphamide-free chemotherapy regime might be associated with a higher probability of menses resumption. Thank you.
Thank you, Dr. Mukesh. That was a
Sorry
nice
for such a short presentation, sir. These were the slides given to me, and I could not add much due to some preoccupations.
No, you have nicely presented, and you have the message has been given that we have an option in some patient to come to us and they want you see pregnancy is important to young women, so they have one this thing that we can think of using paclitaxel only instead of cyclophosphamide so that pregnancy can be preserved. Thank you very much, and now we proceed to our next. That is HER2 positive breast cancer. And for this, I request Dr. Sachin Gupta, our colleague, senior, that he is a director medical oncology and hemato-oncology in Max Super Specialty Hospital. So Dr. Sachin needs no introduction. Please, Dr. Sachin, please chair this session.
Good evening, sir, and thanks a lot for having me here. And it was a pleasure. And we had a lot of exciting topics already discussed, starting with HER2 HR positive, and then there was a talk on continuation of care for HER2 positive, then triple negative. So very enlightening talks and discussions have already happened. And so now this is the last session for the evening, and this is focused on HER2 positive breast cancer. And so there would be two talks here, and by Dr. Satyankar Gupta and followed by a talk by Dr. Ashwin Philip. And so HER2, in HER2 space, a lot of things are happening. As we know, there are so many drugs. Dr. Gautam has already delivered a lecture. And so on one side, we are doing giving more and more drugs, combining trastuzumab, pertuzumab, involving TDM1. And on the other hand, we are trying to de-escalate for patients who need less of this. And especially in a resource poor country like ours, there's a need to actually find out that what exactly needs to be done and individualize the treatment for the patients. So to begin with, I'll invite Dr. Satyankar Gupta, who is consultant medical oncologist at American Oncology Institute at Jammu. So he'll be enlightening us on the article, De-escalated neoadjuvant pertuzumab plus trastuzumab with or without weekly paclitaxel in hormone negative but HER2 positive early breast cancer. So this was a DAPT study from West German study group. And Dr. Satyankar, the stage is all yours.
Good evening, sir. Sir, I think there is some network issues from Dr. Satyankar end. So can we go to the next talk? Meanwhile, he is joining again.
Okay, Dr. Ashwin, you are ready? Then we can invite you first.
Yes, I'm here, sir.
So you'll be speaking on individual patient data meta-analysis of 5 non-inferiority randomized control trials of reduced duration single agent adjuvant trastuzumab in HER2 positive early breast cancer. So again, as I said, there is need of de-escalation and using less treatment wherever possible. So we'll have discussion in practice how much we can do that. So let's hear from you what exactly these trials are saying.
So thank you for the introduction. And the disclaimers, these slides are short. And can you see my slide?
Not yet.
Does it come now?
Yeah, coming. At least not visible to me. Yeah, go ahead.
Yeah, so we're going to look at this meta-analysis which looked at non-inferiority studies, and the 5 non-inferiority studies were look at the meta-analysis to see whether de-escalation from 12 to 6 months was good enough, or would that be a standard of care. So on one hand, like Dr. Sachin had said, the thing is that you want to use pertuzumab, trastuzumab, TDM1 and go ahead, and on the other hand, you're saying let's cut it short. So the entire thing comes from the fact that the FINHER study showed that 9 weeks of trastuzumab versus no trastuzumab was better. So something is better than nothing was what it showed in the FINHER study. Then suddenly everybody thought, let us now expand it to see what is the best option, 9 weeks, 6 months and 12 months. So what they did in this, the authors of the study, what they did is they looked at individual patient data, and they looked at this 5 non-inferior studies, and which are randomized studies, and looked at the duration 12 months versus less than 12 months and 12 months versus 9 weeks to see what is the best way of de-escalation. Now, few of these studies were government-funded studies, like the Persephone study was partly funded by the UK government. So the entire fact is like, it's like our Ayushman Bharat, where the government is trying to see where we can cut short on these guys. So that is how this entire thing comes up. So if you look at the studies, most of them are government-funded, but it is important to actually look at the patient that you really want to give it or not. So from that point of view, if you look at this study, this was a paper that looked at 5 non-inferior studies, and out of this, 3 of them, the Persephone, the FAIR and the HOG study, which is a Hellenic study, looked at 12 versus 6 months, and the SOLD and the short HER2 looked at 12 versus 9 months, 12 months versus 9 weeks therapy. Now, the primary outcome was invasive disease-free survival. Secondary outcome looks at distant disease-free survival, overall survival, and breast cancer-specific survival. Now, when they did the analysis, they looked at the intent to treat population, and because this was a heterogeneous population, they used specific statistics, like the Cochrane's Q statistics. And when they looked at the comparison for 12 months versus less overall, they wanted to use a one-sided 2.5% significance was used. If you're looking at 12 months versus 6 months, they used and for the 12 months versus 9 weeks, they looked at 5% significance was used. Now, if you look at each study specifically, if you look at the Persephone, like we discussed before, at the median follow-up of 5.4 years, what they saw was that 6 months, that is the DFS was 13% in the 6-month group and 12% in the 12-month group. So if you look at the hazard ratio and if you look at the non-inferiority, it showed that the 6 months was probably non-inferior to the 1 year of therapy. Now the FAIR, on the other hand, was other studies which did not show the non-inferiority. The Persephone showed that yes, probably 6 months was okay as compared to the 1 year. But the FAIR study, if you look at it from the other point of view, did not show the non-inferiority, did not touch the non-inferiority margin, and hence it was considered as a negative study. So at this point of time, most of the patients, or most of them have said, if you have to give, it will be better to give 12 months versus 6 months. Now, the Hawk study again looked at it from another point and looked at these patients, and again looking at the distant disease relapse in 12 and 6 months group, again showed that the 3-year DFS was 95% versus 93% in favor of the 12-month group. And if you look at the overall survival, there wasn't, and cardiotoxic, there wasn't much of a difference. So if you look at the non-inferiority margin in this study, it came to be shown as a non-inferior. It is non-inferior. Now, if you look at the 9 weeks therapy, this is where based on the Finher study, they looked at 9 weeks versus 1 year, and none of these studies, actually both the short hair and the SOL, showed that 9 weeks could be better. At the end of the study, what they differed in the what they conclude in the SOL study is that the dose of docetaxel maybe to 100 to 80 to 100 may have been the better option, but other than that, they could not prove that the non-inferiority of the 9 weeks versus 1 year. Similar with the short hair, again the same thing. If you look at the short hair if you look at the short hair study also, again the fact that it did not show that 9 weeks was non-inferior to the total 1 year of therapy. Now, if you look at the comparison of all the studies together, so what they did is they look at all these individual studies, collected the patient's data from each, and the Persephone study had the data already in the study, so they looked at that, and they looked at because it's a non-inferior study, they had to keep a margin, and for all the studies together, they kept a margin of 1.19% hazard ratio with absolute 2% margins, and for the 3 trials which had 12 months versus 6 months, it was 1.2. And for the weekly 9 weeks versus 12 months, it is 1.25. Why this is important, the entire stats is that the moment you do a non-inferiority study is that the moment your margin goes above the specified margin, it cannot be called a non-inferior. It is not a non-inferior study. So if you look at the data here, what they found out is when they analyze the full data as a meta-analysis, if you look at 12 months versus 6 months, 12 months versus 6 months, so the IDFS, then invasive disease-free survival was 89 versus 88.56. Hazard ratio is 1.07, and the non-inferiority with p-value of 0.02. Now, if you look at the 12 months versus 9 months, 9 weeks, again, what the problem here is the hazard ratio came as to be 1.27, which is your pre-specified had to be within 1.25. So it did not touch it did not show the non-inferiority. So by this study, what they would have concluded is that when you analyze all the 5 non-inferior studies, they said that 6 months of trastuzumab is probably non-inferior to 12 months, but although 9 weeks is not. But again, if you're looking at a resource constraint setting, I always practice this in my practice is to see that don't forget the Finher study, at least some trastuzumab 9 weeks is important than giving no trastuzumab at all. Thank you, sir.
Thank you, Dr. Ashwin. So that was short and crisp. So, but this is a exciting data, but what do you do in your practice? And do any of the major guidelines bodies tell us to use 6 months or 9 weeks? Let's throw some light on that.
So the one thing that I realized when I go through the entire study is none of your studies specified what was the number of patients who had nodal disease burden, which was a T3, T4. All these patients in these studies are early stage. And in the West, my consultants always taught me that in the West that an early stage could be 2 centimeters and less. So it is very difficult. And when you compare that to the Indian patients where you see T3, T4, I have no doubt that if you have to use 12 months, you have to use 12 months. There's no question about it. But the problem comes in when you have this T1C, N0, such patients, whether 6 months is good enough or whether that is for 1 year. But you have the APT trial, which looked at 12 weeks of paclitaxel and trastuzumab for 1 year, which is something which I practice in clinical practice. If you have a T1C, N0, then I use 12 weeks of paclitaxel and trastuzumab and then continue trastuzumab for 1 year because the target therapy goes on and you minimize your chemotherapy on the other side. But if your patient can't afford, it makes more sense that you give at least 9 to 12 weeks of weekly trastuzumab, at least something rather than giving nothing at all. So that is what I practice very clearly.
Yeah, that makes sense.
And if the nodes are positive, definitely. I'm clear
Yeah.
on giving 1 year.
So most of us are probably doing this only, that whatever, duration of trastuzumab we are able to give, we are trying to give. But I'm following 1 year wherever possible. And otherwise 6 months is the next target. And in a very, if the resource crunch is too high, then maybe 9 weeks is the next, achievable target. And so, but the problem is now compounded because now there is new adjuvant pertuzumab. Then we have, according to pathological CR, we have to, make amendments to the treatment and whether to add TDM1 and whether to give chemotherapy in adjuvant. So there is a, now this data is when we are using only trastuzumab. So if we add pertuzumab to this, then things totally change. Then the parameters and your thresholds and landmarks and goalposts are changing there.
Then it is 1 year.
And now the cost of, since the cost of trastuzumab is going down with generics coming in, and the every year the costs go down. So the cost thing also will be circumvented to an extent in a lot of patients. So to conclude, we can use whatever duration, and 1 year is the ideal thing still. 6 months is nearly equally good. And if nothing can be done, and at least 9 weeks or 3 months, whatever we can give. Will that be an okay conclusion, Dr. Ashwin?
Yeah, I also agree the fact that if you're going to give neoadjuvant chemotherapy, then you better stick to the TCHP 1 year thing, because that means you're giving a locally advanced disease, you're looking for the PCR. The surgeon is operating upfront and he sends it to you. I think if it's T1, up to T1C, you can probably use 6 months. But after that, you're a bit touch and go. So, I mean, you don't want to be shot by the patient. You offer him the best. 1 year, a bit of overtreatment will not do any much of harm, sir. I mean, that's a little bit.
We are, in such situations, we are biased towards overtreatment most of the times. Yes. It's a situation similar to like Hodgkin's lymphoma, where we get good results and then we want to de-escalate and try to avoid toxicity.
If you read Hodgkin's, it is very difficult because everybody has done two ABBD, 15, 20 gray, 40 gray. Because the disease is good, so you can actually play around a bit too much on that.
Yeah, similar thing happens here also.
Yes, sir.
All right, thank you. So we move on to the last presentation. So Dr. Satyankar has joined now, and I've already, should I tell the topic again? Satyankar, we can go ahead. De-escalation of neoadjuvant pertuzumab, trastuzumab, with or without weekly paclitaxel in HER2 positive early breast cancer. Yeah, go ahead.
Yeah, that's right, sir. Thanks for the invite. So it's the West German study group, adjuvant dynamic marker. I'm on mute. Okay. Adjuvant dynamic marker adjusted personalized therapy trial. It is commonly known as the WSG ADAPT HER2 positive hormone.
Satyankar, you can enable editing and go to full screen for the presentation. Otherwise, slides would be of smaller size. Yeah.
Full screen.
No, not this.
On the top, there is enable editing. Maybe you have to first go on that. Yeah.
Then go to PowerPoint mode.
I think it's okay.
Not yet. Lower down there's a slideshow button.
No, not this, not this. Yeah, exactly.
Yeah.
Yes.
Yeah.
So this abstract was abstract 503, and it was presented at the ASCO annual meeting 2021. And the title of the trial was De-escalated neoadjuvant pertuzumab, trastuzumab with or without weekly paclitaxel in HER2 positive hormone receptor negative early breast cancer. ADAPT HER2 positive hormone negative, and this was the biomarker and the survival results. The same group had actually published the PathCR data way back in 2017 with the PathCR data. So the background, optimal use of de-escalated and potentially even chemotherapy-free neoadjuvant regimens in HER2-positive early breast cancers is currently unclear, as there are limited survival data so far. In the ADAPT HER2-positive and hormone receptor-positive, the same group demonstrated excellent PAT-CR rates as well as survival only after 12 weeks of neoadjuvant TDM1 plus minus endocrine therapy. But in this trial, the investigators saw an excellent PCR rate of around 90% after 12 weeks of neoadjuvant weekly paclitaxel plus pertuzumab and trastuzumab, and a substantial and a clinically meaningful PAT-CR rate of around 34% after pertuzumab and trastuzumab alone in HER2-positive, hormone receptive, negative early breast cancer. And there in this presentation, in the abstract presentation, they have presented the first survival data for the trial. So this is the study design. The patient had to be HER2 positive, ERPR negative. They had to be metastasis free. ECOG performance status was less than or equal to 1. And they were randomized into arm A versus arm B. Arm A was a chemotherapy free regimen. It constituted, only trastuzumab and pertuzumab was given and no chemotherapy was added. But in arm B, trastuzumab and pertuzumab was given along with weekly paclitaxel, the conventional paclitaxel, and the randomization was done in 5:2. And at the end of 12 weeks of therapy, surgery was done within 3 weeks. And the other key component of the trial was to study the early response assessment, and it was defined as Ki67 decrease more than or equal to 30% versus baseline, or low cellularity, that is less than 500 invasive tumor cells. Now the randomization was done 5:2 because at the analysis, it was expected that around 60% patients in the arm A, that is the chemotherapy-free arm, will be non-responders. So to equate for the early responders, they randomized the patient as 5:2. So early response assessment, you can see the arm A and arm B, and it was done after 3 weeks. So at 4 weeks, core biopsy was done, and then 3 more blocks of chemotherapy was given, and then surgery was done. And the primary endpoints of the trial were PAT-CR, that is YPT0 or T in situ, or YPN0, and they also wanted to study the invasive disease-free survival, the distant disease-free survival, overall survival, safety, and translational research was also a key component of this trial, wherein they saw the association of RNA expression signatures, IHC markers, the stromal tumor infiltrated lymphocyte cells, and with PCR and IDFS, and they used the nanostring breast cancer 360 panel and the conventional IHC. And why did they do this translational research? Because they wanted to analyze and the search for predictive biomarkers, if any, for the de-escalation in HER2 positive early breast cancer patients. Baseline characteristics in the arm A versus arm B. Median age was more than 50 in the majority of the patients, and majority of patients were clinically T1 and T2 in both the arms. And node negative patients were around 54 to 60%, and mostly were high grade, as we expect with HER2 positive tumors. But HER2 IHC3 positive were around 85% in arm A and 90% in arm B, whereas patients with HER2 IHC1 or 2, which eventually turned out to be FISH positive, they were also included, and around 14% in the arm A and just about 10% in the arm B. And Ki67 median was around 50% in each of the 2 arms. Median follow-up was about 60 months. So this is the PAT-CR data, which was published by the same group at Annals of Oncology in 2017. And we all patiently listened to Dr. Gautam Goyal, and sir was deeply mentioned about all those trials with the PAT-CR of around 50%, 60% with the NeoSphere and the NOAA and so many other Trifina trials. But in this trial, they reported a PAT-CR rate of around 34% with pertuzumab and trastuzumab, whereas in the pertuzumab, trastuzumab, and just weekly paclitaxel for 3 months. And this study group, they revealed a PAT-CR of around 90%, which was very high. Now, early response was also studied in this trial, as I mentioned earlier, a relative Ki67 decrease of around 30% versus baseline. that is a proliferation response, or less than 500 invasive tumor cells in the 3-week biopsy, there was a cellularity response. Now, why this was important? Because as high as 26% patients were non-responders. And when we look at the PAT-CR in the non-responders, it was just about 8%. Whereas the early responders, which were around 41% of the patients, the PAT-CR was more than 44%. And there were few patients, 32% patients, where a response could not be evaluated either because the tumor was not clearly discernible, localized by ultrasound, or the biopsy, cellularity and Ki-67 could not be inferred properly. So these are the primary endpoint data. The invasive disease-free survival, we can see numerically in the chemotherapy combination arm, it looks 98% 5-year IDFS versus 87%, but the p-value was not significant. The similar was the data with the distant disease-free survival. It was around 98% versus 92%. And overall survival, now this is very important, whether you give a chemotherapy combined arm or whether you give a chemotherapy free arm, the 5-year overall survival was 98%, 94 versus 94%. So it was not statistically significant. But IDFS, when we study IDFS in patients who achieved PAT-CR versus non-PAT-CR, the 5-year PAT-CR rate was around 98%. A 5-year IDFS rate was around 98% in patients who achieved a PAT-CR versus just 82% in patients who did not achieve a PAT-CR. Now, specifically coming to arm A, where we gave only pertuzumab and trastuzumab and no chemotherapy was given. If you see in arm A, PAT-CR, the 5-year IDFS was around 98%, whereas the patients who did not achieve a PAT-CR, the 5-year IDFS was 83%, so which was approaching statistical significance. So what was the benefit of neoadjuvant chemotherapy-free regimen? So when we specifically studied the trastuzumab and pertuzumab, the arm A, according to the molecular subtype, HER2 neu status, and the early response, we can see in the pie diagram, most of the patients that would benefit were obviously HER2 positive patients. And PAT-CR, if you see the basal type, none of the basal type patients achieved any kind of PAT response. And the HER2, which was either 1 positive or 2 positive, or even 2 positive and subsequently FISH positive, these were called non-responders, and this was the non-sensitive population. So clearly the basal patients and the low IHC expression were the non-sensitive population. Now, why this was important, when we studied IDFS in the arm A population and the non-sensitive tumors, so 5-year IDFS was again lower in the non-sensitive population versus 93% in the other population. So this is a graphical representation of the when we studied the these RNA signatures associated with PCR and IDFS. On the left side of the of the picture, we can see on the x-axis we are studying the PAT-CR, on the y-axis it's the IDFS. So from 0.1 to 1 and 10, the responses are better, and from on the y-axis we go from as we go towards the right side, it's the worst response, but worse IDFS. So the RNA signatures wherein there is high the signaling signatures are seen, or the HER2 positivity is seen. So they are the ones who are doing better with PAT-CR and IDFS, and the P10 signaling signature, the patients who had a positive P10 signaling signatures did worse. And when we see only the arm A, that is the neoadjuvant chemotherapy-free arm A, they actually studied around 700 genes in this study. And here also, if we see ER positive patients or B2 positive, that's HER2 positive patients, they did better. And similarly, FOXA1 gene expression patients also did better. But the patient who had BRCA-NES, similar to a triple negative or the basal type, they did the worst. So to conclude, for the first time, this study group in a prospective multi-center trial has shown both excellent PAT-CR rates and survival in patients treated with a de-escalated 12-week neoadjuvant weekly paclitaxel and dual HER2 blockade, irrespective of additional chemotherapy use. Chemotherapy-free regimens are promising in highly sensitive tumors in patients with early response. Further investigations of chemotherapy-free regimens need to be focused on selected patients. Example, HER2-3 positive patients, HER2-3 positive patients, non-basal-like patients, early responding patients, and predictive RNA signatures such as immune signatures. In this trial, early PAT-CR only after 12 weeks of neoadjuvant paclitaxel plus pertuzumab trastuzumab was strongly associated with improved outcome and may thus serve as a predictive clinical marker for further treatment de-escalation. Similarly, in the West WSG ADAPT TP2 trial, they have already reported a PAT-CR of around 57% in HER2 positive, hormone positive early breast cancer after 12 weeks of neoadjuvant paclitaxel, pertuzumab, and trastuzumab, but the survival results are being awaited. Further de-escalation trials with similar concepts, example the COMPASS trial and the DCrescendo trials are ongoing. So these are the acknowledgements. Oh, sorry.
Yeah, thank you, Dr. Satyankar. That was again pretty comprehensive. And so in your practice, in which kind of patient subgroup or which kind of patients age-wise, or how would you choose to use this information for de-escalation?
As of now, I don't think anybody is practicing de-escalation therapy, but this trial and maybe similar trials, they are quite promising, and they have clearly shown that patients with early responders, we don't do biopsy at 3 weeks. So, and we don't, neither we do the molecular, these gene expression signatures also, which might be, of, some use in times to come. But currently, we're not using the de-escalation therapy.
Yeah. So we have been using, paclitaxel with trastuzumab, pertuzumab in some elderly patients where we find that docetaxel may not be applicable. So that particular thing has been tried in, a small number of patients, and with, of course, excellent results there, which has been found equivalent to using docetaxel. Now, in this particular trial, the one thing is evident that even weekly paclitaxel is very important here. There are two concepts. One is that whether we can avoid paclitaxel totally, but avoiding paclitaxel is not giving us good results here. Actually, if we see finally, then pathological CR is 90% where paclitaxel is being used versus only 36% with dual HER2 therapy only in the overall group, right? So paclitaxel is a very important part of this arm. And there are very few patients who would not be tolerating weekly paclitaxel, right? So that's a very, very small number of small percentage of overall patients. So most of the times we would be able to use weekly paclitaxel at least when we combine all this. And so from what I gather from this is that using paclitaxel is very important, and that adds a lot of benefit to the pathological CR, and which is important for final outcome. Now they have dissected a subgroup where only dual HER2 therapy may be beneficial and chemotherapy can be totally avoided, and which is a strong HER positive and non-basal type. So basal is totally, in the basal subgroup, the responses were just 0%.
Yeah.
So that needs to be highlighted, that basal is totally not benefiting. And non-basal, in the non-basal, it was about 36% pathological CR, right? Yeah. So which is again inferior to versus using paclitaxel. So I again want to stress on the point that using paclitaxel becomes important here and should be doable in most of the patients. And the very high pathological CRs, which they have found in this particular trial is actually astonishing. And it's exciting and astonishing, and maybe we can use this more often in practice, because after achieving pathological CR, they have not used any chemotherapy in these patients. So they continued with only dual HER2, and the final results were, if we see 5-year IDFS 98%, and overall survival again 98% versus 90, which is again significant in a breast cancer patient.
Yeah, that's right.
Even 4%, although that was not statistically significant, but it may eventually become, if we see longer data, that may become eventually significant. So to me, it looks promising and exciting and doable in our practice as well, that we, instead of using docetaxel, you can go to, weekly paclitaxel for 12 weeks and followed by no chemotherapy in pathological CR. That makes good sense here.
Right,
and do we have more questions, sir?
I think these were the pearls of wisdom, and correctly said. It's very difficult to give docetaxel as per recommended doses to our patients. 100 milligram who's giving, very difficult to give. And paclitaxel, of course, whenever 2-3 drugs are there, I prefer to use paclitaxel rather than docetaxel. Of course, the peripheral neuropathy is an issue with it. And thank you very much, Dr. Sachin, for giving your expert advice on this breast cancer. Now, I think I try to choose so many things which are happening in early breast cancer, and now we have options. It is option for everybody is there, whether you give proper treatment, you give lesser treatment, whether you can adapt or not in all the three setup. And we have so many exciting things in triple negative breast cancer. So it is between the consultant and the patient. We can only have a guidelines and this thing, but it is a consultant and the patient, depending on where different needs of the patient, as well as the consultant's own comfort level, what treatment can be options. So now we have so many newer options for this breast cancer. So I thank you all the chairperson. I thank you, Dr. Sachin, Dr. Gautam, and Dr. Ashwin, and all other participants who have participated in this today's discussion. And I also want to thank the industry with Roche, AstraZeneca, and TAS, Dr. Reddy's and Zydus for their participation in this today's discussion. And of course, this wouldn't have been possible without the effort of Horizon and Mr. Tarun and his team for making this today's webinar successful. And I thank all of you. And with this, I think we conclude.
Sir, can I ask one question, sir? Just
yeah. Sure.
Sir, in the previous talk regarding the maintenance, this trastuzumab for 1 year versus 6 months. So Dr. Sachin made a remark that with more and more generics coming and the price of trastuzumab, getting cheaper and cheaper every day. But unfortunately, we work in a corporate setup and where prices of trastuzumab have not actually fallen. So the prices are largely the same. So can there be a situation in in the maintenance part? Can we switch the patients to oral lapatinib? Because that will be affordable because patients can directly buy. Because can we do it practically? Is it wise to do it? I mean,
no, wise. Lapatinib is not found to be equal to Herceptin as far as the trials are concerned.
Yeah, that is true. But
of course, obviously, see, you can't ask the patient to sell everything and get treatment and then do. The cost remains absolutely. So that is why there are so many options for a consultant. So you have to take a call with your patient depending on his, of course, the payment issues are more important than everything else. I mean, if you can't give, you can't give, but at least you give something. If you can't give this, then I would say that there's no harm in giving lapatinib to those patients if you want to. But since the FINAR regime as well as 6 months are equally effective, so at least that much you can do. If you can't give anything to anyone, then probably you can try. Yeah, that may be there. So it is very important that patient pocket is the most important thing to do. I mean, rest, everything is there. We require 2 meals. If we can have 2 meals, India that is a problem. We can have billionaires also, and we have people who can't have 2 square meals. So today's discussion, like metronomic schedules and other things, we want to bring de-escalation also. It is all the consultants are to be empowered with the knowledge that they can do, and they won't be wrong in doing because data is there. So we want to present data to you that in a breast cancer, so many things can be done in this.
Right, sir.
Any comment if somebody wants to give any comment?
Right, sir. That's excellently said. So we have to individualize the treating consultant has to take a lot of decisions, and which may be totally justified and valid in that particular situation.
Absolutely.
Yeah.
So again, I thank everyone, and of course, I thank Horizon also for
Thank you.
putting up so much of effort and making this.
Thank you, sir. Thank you so
webinar
much.
itself. Thank you very much.
Thank you, and good night, everyone.
Good night.
Thanks for joining. Thanks for the excellent presentation and discussion. So, good night, everyone. Stay safe. Bye.